Good evening, everyone, guys. Can you guys switch on your camera if you can, so that it will be more interactive? Good. Right. So let us start the session. First of all, welcome you all for this taste test session by the PrepMedico FRCS team. So this session, usually we plan 1 or 2 sessions prior to the 3-month course, which starts before every FRCS section 2 exams. It's mainly to give an extra opportunity to candidates, whoever have registered for the course, to have a more warm-up before the course, and also for candidates who would like to know what is this exam all about and get to have some feel about how these vivas and stuffs happen. Yeah. So today I'm going to, I've planned the session for 2.5 to 3 hours. Okay. And it's not going to be, it will be more interactive, more friendly kind of a session rather than a question and answer session. So to introduce myself, I am Manikandan Kathirvel. Most of you might know me. For people who don't know me, I'm the program director for the PrepMedico FRCS courses, and I'm also a consultant HPV transplant surgeon working at the Whittington and Royal Free Hospital, London. And I am representing PrepMedico, which is a firm which has various subdivisions. FRCS courses is one group where we have 25 surgeons who work together, and we have been delivering this course for the last 3.5 years. Just a quick update about the way we conduct FRCS course. It's unlike the other routine intense courses which is available in the UK. Our course is slightly different, where we do it over a period of 3 months. So more of a mentorship kind of a training rather than an intense preparation. Right. So without wasting much of the time, what I'm going to do is I'm going to share my screen first. The first 15 to 20 minutes, I'll be giving you an overview about FRCS Section 2 exams, because many of you here may not be taking up the exams soon. So people are here just to understand what is this exam all about. So I'll be giving you a brief overview about the Section 2 exams, what it involves and what is expected from a candidate. So this is what I'm going to talk. And then we have a 2-hour time for Viva. What I'm going to do is I have chosen one scenario, a basic scenario. I'm not making it more complex. Basic scenario in all the topics, starting from general surgery, critical care, upper GI, colorectal breast. So one session, one topic per specialty, and I'm going to ask for volunteers. So you guys need to come and participate. I know many of them here are already course participants and people who would have given the exams already. So I would restrict to one scenario per candidate rather than same candidate answering many scenarios. And I think it should be more proactiveness from your side to make it more fruitful. And also we have one more session coming up next week just to warm up, if at all, if you're planning to take up the exams in this November. So the whole purpose of this evening meet is for you guys to have a warm-up on what is this exam about, how you should start your preparation, and some examples of how a scenario would be. That's the whole purpose. And you can stop me anytime. I'm not going to time you for any of the responses. I'm going to be giving you feedbacks now and then on important Viva techniques rather than the knowledge itself. I'm pretty sure you may not be having much knowledge now to answer effectively, but what I will be trying to teach you is the essential Viva technique, which is very essential and the key factor for clearing these exams. Right. Let me share my screen. Just give me a second. Screen. Just a moment. Sorry. Just a minute. Okay. Hope you can see my screen, yeah?
Yes,
Perfect. Oh, Kaldon, good evening. How are you?
I'm fine, thank you.
Good. Right. So let us start. So the session agenda would be, I'm just going to give you a very brief overview about FRCS Section 2 exam, specifically the JCIE exam. I'm not going to talk more about the international FRCS exams here, just not to dilute the intensity of the session. And then we will have 2 to 2.5 hours of Viva, touching on various topics in different specialities. And then finally, we will have a feedback and a conclusion session. And then I will be briefing you something about our upcoming course, which is starting next week. And as I put up in the advert, this session is being recorded, and we will be utilizing this recording for future teaching purposes. So if anyone has any issues with that, you can tell me, and you can feel free not to participate. It's completely up to you. Okay. Right. So the FRCS Section 2 exams happens on 2 days. So there is one full day and there is another half a day. Okay. So the total exam is divided into two groups. One is the clinical examination, another one is the Viva examination. The half a day component of your exam. So as I told, 1.5 days you'll be giving this exam. In that half a day, you will be having this clinical examination. So there will be two clinical examination tables or sessions, whatever you call it. And each clinical examination would last for 40 minutes. Okay. In this 40 minutes, you will be handling one long case and two short case. The one long case is for 20 minutes and two short cases is for 10 minutes each. Again, as I told, there are two clinical examination sessions. One will be in your general surgery and other one will be your special interest surgery, which you choose. Okay, so this is the half a day of your exams, where previously, before the COVID, this session used to happen in the hospitals, university hospitals, where you will be having real patients. But post-COVID, things were changed to complete case scenarios. But now, for the last 2 or 3 exams, what they have done is, for the long case alone, they bring in actors. So they bring in actors. So you need to speak to the patients or the actors to get history from them. But for the short cases, you will be just given case scenarios and you'll be discussing. So there is no, although it is termed as clinical examination, you won't be physically examining any of the patients here. Okay. So this is for 40 minutes, one long case, two short case, and in your special interest, you'll have one long case and two short case. So in each of these sessions or tables, in this 40 minutes, you will be sitting in a table where you will be having two examiners sitting on the opposite side. And any time of the exam, there will be one examiner who will be questioning you, and the other examiner will be marking you. And they alternate among themselves. At the end of 20 minutes, there will be a bell which rings, and then you move on to the short case, another 10 minutes, and then another 10 minutes. So this is the clinical examination component of the Section 2 exam. Then we have the full day, the Viva day, where you have 4 sessions. One session is for emergency and trauma surgery. The second session is for general surgery principles and clinical practice. Third session is your special interest surgery. And the last would be your special interest surgery basic science and academic paper interpretation. Okay. So here in the Viva, again, exactly like the previous clinical examination day, you will be going and sitting in a table for 30 minutes. Okay. The clinical examination is for 40 minutes, but this is for 30 minutes. You will sit in a table with 2 examiners, and you will be having 6 scenarios in each table. So if it is an emergency surgery, trauma, critical care session, you will be having 6 short cases or short scenarios, which you will be discussing 5 minutes each. Similarly, in the general surgery table, you'll be sitting with 2 examiners, and you will have general surgery scenarios, which you will be discussing for 30 minutes. And then you have a special interest surgery table where, depending on whatever specialty you have chosen, you will have short 6 scenarios for you to answer. And then the last table or the last Viva is your basic principles and academic foundation, where 15 minutes, you will have 3 scenarios of basic principles in your specialty. And then the next 15 minutes is for you to present and critically appraise an research paper. So before this fourth Viva scenario, you will be given half an hour time with a manuscript where you'll be sitting in a table, you make all your notes, and then you come to this point. Usually this scenario or station starts with presentation of your academic paper. So 15 minutes, you'll be presenting the paper. Questions will be from basic statistics, how to interpret the paper. And then the next 15 minutes, you will be having basic principle questions, which will be the basic science in your specialty. If you see if you see the clinical examination and the Viva examination, 50%, nearly 50% of your questions comes from your special interest or your specialty. If you are a colorectal trainee, you will be having 50% of your questions from colorectal specialty. The rest all will be from all the specialties. It could be starting from general surgery, critical care, all of the specialty. The reason why I am telling this is the preparation for the Section 2 exam should be very, very smart. Okay, hard work alone doesn't help you. You sit from today for 4 months, study 8 hours a day, it's not going to help you. You should, because the syllabus is so vast and it is impossible for anyone to study everything. So you should be very, very smart, knowing which area you need to cover as a trainee of that particular specialty. So if you are a colorectal specialty, you need to be a consultant. You should have a consultant level knowledge in your colorectal surgery. So your priority is to master colorectal surgery, including everything, the recent guidelines, recent research paper, everything. And then the next step would be your general surgery and critical care, because that is essential for any general surgical practice, irrespective of your specialty. And then comes all other specialties. So you don't need to stress too much studying in depth in other specialties like HPB, transplant, endocrine, vascular, etc. Okay, so you should have a smart study plan before you initiate your preparation. So what is expected in this exam? So many candidates, especially the immigrants who are not the local trainees, they would have been used to a system where in your country, the examination is basically they ask you questions, they test your knowledge. Most of the exams in most of the other countries, the surgical exams are designed in a way that they test your hardcore knowledge. But the FRCS Section 2 exams is slightly different. Okay, what they expect is, yes, you need to have a knowledge to be a consultant, but at the same time, they test various other things, starting from what is your professional behavior, how do you communicate with the patient. Basically, what I say is a Section 2 exam is like a consultant interview day. So the 2 examiners sitting on the other side is interviewing you to decide whether they can take you as a consultant to work under their team. This is how you need to consider this exam and prepare. This is not an exam to test your clinical knowledge. This is not an exam just to test your communication skill. It is a holistic thing where they are checking whether you are a safe consultant to work, or you should have a knowledge equal to a day one consultant. So this is how it is discussed. And then if you see, majority of the examination sessions would be like a discussion between 2 consultant colleagues rather than an examiner and a candidate. Although this doesn't stay true in few situations, because there are few very strict consultants who stick to the old way of asking questions and answers, but majority of the examiners, they treat you like your colleague, and it will be like a 2-way discussion where the examiner and the candidate contributes equally to a scenario discussion, rather than just a leading question and the candidate answer. Okay, and you will be treated with respect. Majority of the time, it's a 2-way conversation, not like an MRCS exam where they just have a fixed question and they have a key answers in their hand where they test whether you're telling the right answer or not. And the assessment is based on how you think. Okay, it is not about whether you are clinching the diagnosis properly or not, but how you think in that particular scenario for that particular patient. And then how you process your differential diagnosis. What is expected here is, as a consultant, you should have a broad mind and you should have a consultant level knowledge to have the differential diagnosis in your mind to choose. That is what we call it as an higher order thinking. You need to express your higher order thinking when you answer in this exam. So whenever, say, for example, you get a question where you have a post-op patient whom you are called to see in the ward who has breathlessness. Yeah. Of course, many of us in a surgical background, we all think it's a DVT, but what is expected in this exam is, so you are worried about the situation. You need to tell how you think in the situation. I am extremely worried about the situation because a patient following a surgery should not have breathlessness in the ward. What is running in my mind is the breathlessness could be because of medical problems or it could be because of surgical problems. The medical problems are 1, 2, 3, 4, 5. The surgical problems are 1, 2, 3, 4, 5. This is how you express your higher order thinking. And then you approach the patient and you need to express the way you process the patient's symptoms, signs, and the blood test to approach to a diagnosis. This is what they test in this exam. This is not an exam where their question is asked and they check whether you are telling the right answer or not. And majority of the situation, you may not have a single right answer for any question. For example, say you have a patient who has a pancreatic trauma. Patient is doing absolutely fine. So how do you manage this? There are many situations in surgery where you don't have a single right way of approaching the patient. And in your own clinical practice, you would have seen one consultant treating a patient in a way and another consultant treating the patient in a different way. So in the exam, what they check is how you would approach the situation. So that is why whenever you answer in this exam, you need to tell what you will do. Okay, say you have a patient who's presenting to you with a bilateral inguinal hernia. What will you do? You cannot tell that the methods of treating this patient is you can do a laparoscopic approach, you can do an open approach. It is recommended that laparoscopic approach is better for a bilateral inguinal hernia. Open. You should not tell this. You need to tell that, okay, I will go and see this patient. I will explain this patient that there are two options are available. However, in my personal practice, I would suggest that it is better for the patient to undergo a laparoscopic hernia repair. You won't be penalized if you tell that this is a bilateral inguinal hernia. I am aware that laparoscopic hernia repair is best for this patient, but I am not well versed in doing laparoscopic repair. So I would suggest to go ahead with an open repair. You can tell that. So what is expected is what you will do in this situation. That is what is expected rather than listing what are all the options given in a textbook or in a paper or something. Okay. And as I told in the last two exams, we have actors sitting in the session for your long cases. Sometimes these are real patients. So you need to develop the habit of taking case history from the patient for you to present and give your differential diagnosis. So you will be having actors only for your long cases. So in your entire exam, you have two actors, one for your general surgery long case and another one is for your specialty surgery long case. And your aim is you need to get a focused history in 4 to 5 minutes. In 4 to 5 minutes, you get a quick history from the patient where you exhibit all your professionalism. You cannot be jumping and getting the point. You need to introduce yourself. You need to be utmost professional in that situation and show and express your communication skills there. And at the end of 5 minutes, you present the history, and from there, the examiner will take you asking various questions on how do you improve and stuff. So if you see in your entire section 2 exam, so you will be facing around 20 to 25 scenarios, if I'm not wrong. Yeah. So any scenario, the first 1 or 2 questions will be the easiest question to answer. And the difficulty of the question increases as you sail through each scenario. Okay. So the aim of a candidate or the simple trick to pass this exam very easily is you need to make sure that the first and the second question, which is the easiest questions in that particular scenario, you should just blast it out. You should use these 2 questions to express who you are. Okay, that answer should tell your experience in surgery, your experience in handling the your experience in how safe you deal with the scenario. So that is what we call it as a landing sentence. So the first answer which you tell the examiner for any scenario should be a very smart answer, which will make the examiner to think that, yes, I am dealing with an experienced person, so he should be a good person. So he will feel very relaxed, and from then onwards, the examination will be very, very smooth. And also, I need to tell you that the examiners are given a theme and an area to cover. They are not given a specific question to ask. For example, say you are a colorectal specialty person and you are going to discuss a scenario where you have a colorectal cancer with liver mets. So this is a scenario. So the scenario will be, they will be given a history in their question booklet, and following that, they'll be having 5 or 6 areas to cover. It will start with history and examination, and then you will have investigations. Third thing, the neoadjuvant treatment. Fourth thing will be what are the trials, and fifth thing will be liver first approach. Sixth thing. So these are all the themes which will be given for the examiner, and the examiner can choose any question in the theme. So there is no set of a fixed question for every candidate. The examiners are given themes, and they can ask you a most difficult question or most easy question. So that is why the key in this exam is you need to keep the examiner very, very happy. Yeah, you should have a very pleasant face. The way you sit, the way you answer should make the examiner very calm, peaceful, and composed, so that he will be happy and he will feel more motivated to ask you questions. And if you start irritating him by any way, for example, answering in an argumental way, or answering or giving not having a very polite look, will irritate the examiner, and the examiner can ask you very difficult question to fail you in that session. So although that is not expected, but because you are given themes for the examiner to ask, the the total control of that session is in the examiner's hand. And what I always advise my candidates is, you should have the skill to take the examiner with you rather than you following the examiner. You go there, introduce yourself, always have a smiling face, discuss in a very professional way, and never argue with the examiner, because as I told, many questions may not have a single right answer, and you will be telling something, the examiner will be discussing something. Even your tone of language should not be in a way that you are contradicting the examiner's view. So this is how you need to present. And of course, although these exams are very high-end exams, the scenarios which are asked in the exam are quite common, but in a very complex background. For example, you won't be given a simple scenario like you say a 50-year-old fit and well patient with a right inguinal hernia. How do you manage? You won't be getting a scenario like that. You will get a scenario like, okay, you have an 85-year-old male who has a performance status of 2, which is taking dual antiplatelet medication, has a pacemaker in situ, and has a background Marfan syndrome, coming to you with the symptomatic inguinal hernia. How do you manage this? So this is how the scenarios would be. It will be a complex scenario for you to plan various things, involve multiple doctors, evaluate, and plan the operation. But however, the common things are common. So any differential diagnosis you mentioned, you need to mention in a the common things are on the top, and the diseases or the scenarios which is discussed are also more common than very rare scenarios. Okay. The most important question which many candidates ask me is about the evidence, evidence, recent guidelines, recent research paper, etc. So in a scenario, when they reach to a question where they ask you what is the evidence, or if they ask you what is the recent trial comparing, say, stent versus no stent with an obstructed sigmoid tumor, if they had come to that point, it means that you have already passed the session, and that question is for you to score the full marks in that session. So evidence is important if you are aiming for a gold medal. Okay, one. Second important thing is, it doesn't mean that you don't need to know evidence. You are expected to know some basic and standard evidences and landmark trials in your specialty. But more than that, knowing or not knowing the evidence is not going to, fail you. That's the most important thing which I want to tell. So your aim in preparation of this exam is to make sure you build your foundation knowledge, you focus on your Viva skills, make sure you speak normally, and develop the practice of answering everything you want to do within the time frame. That's the most crucial bit in this exam. Here, people will be knowledgeable, people will be happy to speak, they don't have this language problem, they'll be fine. But as I told, all these scenarios are 5-minute scenarios, and you should know what you should talk and what you should not talk. If you say, for example, if you have a patient coming to A&E with abdominal pain, what will you do? If you go and start telling that I will go introduce myself, I will get history from the patient. If you answer that question only, you will answer for 5 minutes. So you should know in 5 minutes time how you will be answering maximum possible questions in that scenario. That should be the aim. Okay. And as I told, structured responses is more important. The problem with this exam is, especially people who are non-trainees from here and who never had this kind of exam in the past, is how to structure the answer. The answer will be running in your mind, but when you want to put it out, you cannot put it out. Okay, that is a problem. And also, when you want to put it out, if you take your time to answer whatever is running in your mind, it would have finished the 5-minute scenario where you would have answered only one question instead of 7 questions which you are expected to answer. So the key for this exam to be successful is practice, practice, practice. Every day, if you're giving the exam in November or something, 3 months prior, you should practice, where you should cultivate the habit of opening your mouth and answering what is running in your mind. That's the most important thing. And also, you should answer in a way that the examiner should think that you are a professional, you have a very mature attitude, and you should answer in a way that you list out or expose all the knowledge which you have. That comes only with serious practice, commitment. Yeah. And in the exam, there will be certain situations where you don't know an answer to a question. You should feel free to tell, I don't know. Okay. You should not try and tell something and try to substantiate your wrong answer, because the examiners here are very, very seniors. They would have seen hundreds and hundreds of candidates like you. And from the time you answer, they will know whether you are bluffing or you're telling the right answer. If you don't know, tell you don't know, move to the next question. Okay. And as I told the same, this is a very important slide which I always show to my candidates, because this is something which I feel that it's not much covered in other courses. Because as I told you, your practice or preparation for this exam should be very, very smart. Okay. As per the curriculum, the knowledge expected from a candidate is you need to have a consultant level knowledge in general surgery and emergency surgery. Okay. And you need to have your consultant level knowledge in your special interest surgery. Okay. If you're a colorectal trainee, you should have a ST8 knowledge in colorectal surgery, general surgery, emergency surgery. In the rest, upper GI, colorectal, trans, breast, endocrine, vascular, upper GI and colorectal, you should have ST6 level knowledge, and all other specialty, you should have ST4 level knowledge. This is what is recommended by the college. But in the exam, it is not true. You need to be slightly higher than what is put up here. For example, I would always say for general surgery and upper GI and colorectal, your knowledge should be ST7, and the rest all you should have an ST6 level knowledge. So this is the amount of knowledge you need. So when you say how do you determine what is ST6, ST7, or ST4 knowledge, I would say when it is ST4 plus or ST5, I would say you need to have an MRCS plus knowledge. So you should know what an MRCS candidate should know, plus little more, okay, in terms of the management, surgical management and stuff. This is what I would say. The rest, all upper GI, colorectal, everything, you should be knowing information up to a level of a consultant. So if you are becoming a consultant today, the amount of knowledge which you would be expected to know as a consultant is what you need. Okay. Again, this is another important thing which I would advise all the exam going candidates to go line by line. I'm not going to waste time here. So this is the marking descriptors which is provided to the examiner when they mark you. Okay. You need to go through this for you to understand how you are marked in this exam. Okay. So every response in your exam, you will be given marks from 4 to 8. 4, 5, 6, 7, 8, in which 4 and 5 are fail. Okay, if you get 4 marks in particular thing, you are fail. 6 is just pass, 7 is good, 8 is excellent. So this is how you are marked. So here they have given when they will give you 4 marks and 5 marks. Okay, so any marking, it depends upon all these things, starting from your personal qualities, professionalism, surgical experience, adaptability to stress, ability to deal in gray areas, knowledge. So all these areas are assessed in every response of yours. And you can go through this. So what is description? You will be given 4 marks if you fall under this category. Okay, you'll be given 5 marks if you fall under this category. And this is something 6, 7, 8 are pass marks. So I'm not going to go in detail. This is available in the JCIE website. Please print it out before your preparation. Go through this 10 times for you to understand what is expected in this exam and how you would have a focused preparation for this exam. Okay, the most key to success is practice, 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 nothing else. Yeah, you need to practice every day starting from day 1 of your thing. Okay, I have seen several candidates who assume this exam to be simple. This is an easy exam as long as you understand this exam. It is the most difficult and an impossible exam to clear if you don't understand this exam. Okay, that's the most important thing. So you need to understand this exam. You need to have a preparation focused on this exam. And most importantly, you need to practice. You need to open your mouth, practice, practice, practice. You need to form groups amongst yourself, which should have different specialty. Someone should question each other and answer. Again, the answering is not just testing whether you're telling the right answer, but it needs to be in a proper language and it should be time tested. You should not be wasting 10 minutes time answering one answer. You need to tell quickly and you need to practice. That's the most important thing. Second important thing is commitment. Okay, I know it is a very, very important exam in a surgeon's career before you become a consultant in the UK or a CCT in the UK, wherever it is. So I would advise you do everything possible in the 3 months time before the exam. The worst thing is sitting back after failing in the exam and thinking back, oh, I should have done this, I should have done that at that point. Okay, that's the worst thing. Okay, you need to know what is your strength, what is your weakness. You cannot generalize all candidates under one roof. Someone would be very confident in knowledge, they may not be able to speak. Someone would be an excellent surgeon, but they may not be able to communicate properly. Someone would be a good communicator, but they may not have essential knowledge. So you should be able to judge where you stand in this and do everything possible in the 3 months. Your time, money, everything you sacrifice now to secure and pass the exam, rather than failing this exam, coming back again thinking that, oh, I should have done this, I should have done that, and go to this. So if you see many candidates, they when they start the preparation, they feel very overconfident. Okay, and then they don't communicate with each other. They just see the website, whatever is given. They go just by studying some books and they fail. Then they realize that, oh, we have not done all these things. Let us do. They will all join all the courses available in the world. 5 courses they will join, and then they will waste money, this and that, waste time, and then they'll be very stressful, knowing that, okay, what to study, because they would have already prepared something. There is no much resources available for you to study more when you fail for once and come back for the other side. Okay, so what I'm trying to tell is, take this exam very, very seriously, and you need minimum 3 months of intense preparation, however good you are a candidate. If you are a weak person by any chance, if you know who you are, if your knowledge is weak, or if you think that your communication is not good, then you need 5 to 6 months of intense practice, intense commitment to move into this exam. Okay, so the most important thing is, start your preparation very early, identify your strengths and weakness, and work on your strength and weakness. Okay, and make practice groups. Speak to your consultants or senior colleagues within your hospital whenever possible. try to sit with them and answer, and utilize every opportunity in your clinic. For example, in your clinic, when you're sitting, a patient comes, assume that that's an exam scenario, and try to practice with the patient themselves. Similarly, when you're going in the ward round, say your consultant comes, you can tell that, okay, I'm practicing for the exam. Can you just question me? You can ask them, right? And um, another important thing is mentorship. Okay, when I say mentorship, you need to find people who are very, very keen to support you and help you. Again, there will be lots and lots of people because all the consultants here have cleared the FRCS exams, but they may not be knowing if anyone who is out of this exam preparation, or if they have cleared more than 2 or 3 years before, they would have completely forgotten what is this exam all about, how to prepare, and things like that. So identify right people who have just finished the exam, or who are teaching regularly, or someone who is extraordinary who will be able to help you. So that find 5 or 6 mentors who should be able to help you in your exam preparation. And as I told, few tips which is very important, and you should know before you start preparing, is exposing your higher order thinking. Make sure whenever you answer, you utilize and think before you answer, and see whether you can impress the examiner by telling certain more points. For example, say you have a situation where you have a cancer. Instead of telling, oh, this is a cancer, this patient will need a left hemicolectomy. Instead of telling that, you would tell, oh, this is a situation where I think I will go and explain the patient. This is the finding. I would quickly discuss in the MDT, and I'll get the MDT outcome. However, the MDT outcome would be left hemicolectomy. So this is how you expose your higher order thinking. And as I told, landing sentence is the first answer which you tell for any scenario. Okay, answer in a proper way. Expose your mature attitude. As I told, no argument, and it should be a very healthy conversation with the examiner. That's the most important key. Sometimes your body language itself would make it look like you are an arrogant person, or your language is quite arrogant. Okay, so you should take the feedback from people to know whether you have such an attitude, and if such an attitude you have, you need to correct it. There is no other go, because I used to see plenty of candidates in our courses where, because of the way they prepared and stuff, their language is not polite, their body language is not polite. So I make sure that I call them and tell that, no, this is not the way. You need to forcefully correct yourself, because the examiner, he who tests you, he may not know whether you are arrogant to him, or your attitude itself is an arrogant attitude. So there is no plan B or C here. You need to be polite, respectful, and pleasant looking in front of the examiner, and answer in a way that that particular patient is under you, and you are treating that particular patient. So this is how you need to answer, as I told before, what you will do in that situation, rather than what anyone else would do or what the textbook describes. And your answer should be crisp and clear. There should not be confusing statements. You cannot be contradicting your own statement. So that's very, very important. Again, that comes only by practice. And the markings, how they do is, whenever you answer, the examiner, obviously, if you don't know a particular answer, the examiner will prompt you. They will give you some clues for you to pick it up and answer. More the prompts comes from the examiner, your marks will go down. So you need to practice in a way that you answer holistically, so that the examiner don't need to pull out every answer from you. Okay. And the last thing I put a thick skin is because, as I told, this is a very, very intense exam. That if you speak to candidates who have given this exam, you know how stressful are these 1.5 days. And you will be sailing through various scenarios which will be running like a bullet train. And say if you have 6 scenarios in a particular station, if the first scenario is very tough, and if you don't know, and many times they intentionally keep the first 1 or 2 scenarios out of 6 scenarios very, very difficult, to put you into stress and see how you think. This is the whole purpose. Yeah. So the first scenario in the 6 scenario session, it may be very difficult and you may not know anything. Many times what happens is the candidate will feel very bad that he has not done well. He will lose his hopes, and that will reflect on his the further sessions, and you'll perform very, very poorly. So that's very important. Again, you need to be very, very, thick-skinned, and you need to be blunt in your mind that once a particular scenario finishes, your mind should become blank, and the way you performed in that particular scenario should not impact your performance in the other scenario. So that you should prepare yourself. You should prepare yourself. You should tell to yourself that yes, even if it is difficult, that's fine. I'm going to do the next one. Even if that is failed, I'll go in the next one. Even if all the 6 scenarios fail, you need to tell yourself, still I can compensate by doing all other sessions very well. Because at the end of the day, the pass mark depends upon the cumulative score rather than one particular area within the score. Okay. And most importantly, another common reason for failures is thought blocks. If you become very, very anxious, you'll become, very anxious on the day of exam. Your mind may not work. So you need to do everything to bring down your anxiety. So how does the anxiety comes down is you need to develop confidence within yourself. How you develop confidence is you need to have a very strong preparation. You need to have a focused preparation. You should have adequately practiced, which will make you feel confident on the day of exam. Still, you will have some anxiety. That is not a problem, but you need to do everything possible to bring down your anxiety. This is what I would say. Okay, right. So this is all the basic things which I want to tell you. I'm going to stop. So this I have put here because I'm going to moving on to Viva now. I'm going to ask one scenarios and everything. So I'm going to stop sharing my screen. Do you have any questions, guys? Any questions here? Anyone so far? Don't think that I had scared you about this exam. Yeah. I need to be realistic, and we need to tell everything very, very clearly before you.
Hello, Mr. Mani.
Yes, who is that?
This is Muhammad Amir.
Hi, Mohammed. How are you?
Hi, how are you? Thank you for this quick presentation. You have talked about the structured way to answer.
Yes.
Is there is any specific structure or scheme how we can use it in all question, or anyone is different?
No,
Each question.
no. When I say structured answer, the answer should be holistic, is what I am trying. There is no fixed structure with which we can generalize for all the answers.
Yeah.
So, for example, simple thing is, say you have a patient coming to a 16-year-old girl coming to A&E with right iliac fossa pain and fever. If this is a situation, and the examiner is asking you what you will do. So you should not answer that, I will go and see the patient by myself, I will take history. This is where you stop. And the examiner will ask you what history you would like to take. Then you will tell one by one. Then the examiner will ask you, what do you think now? Instead of making this, you will tell that I am concerned about the situation. 16-year-old girl with a right iliac fossa pain. I am worried about the various differential diagnoses, starting from acute appendicitis, ovarian torsion, ovarian cyst. It could be mid-cycle pain. It could be a very rare diagnosis like an ileocecal Crohn's and stuff. But I would go and see the patient by myself. I'll get a focused history, including this, and I'll come and I'll examine the patient. This is how you need to answer. This is what I'm telling about a structured response, rather than jumping here and there. Similarly, whenever you answer for a particular question, you should have a sequence. Yeah, you cannot be jumping when you get a history again, like our traditional way. You need to get some history, past history, family history, then you move on to a general examination, this one, rather than jumping here and there. Similarly, many people will forget that, they will, without even getting the history, they will tell that I will start investigating the patient. And without doing a blood test, you will start doing a CT scan. For simple thing is, of course, say you have a patient who has an acute abdominal pain, and you very badly need a CT scan to, diagnose it. You cannot tell that I will take this patient for a CT scan. You need to tell that you need to behave like a consultant. So I will review the blood test, make sure that the patient is not in acute kidney injury or doesn't have any renal failure. Then once that is fine, I will do a CT scan. Similarly, instead of telling you won't score more marks if you tell I will do a CT abdomen with contrast. That is not an answer by an ST8 trainee. You should tell I will do a CT chest abdomen pelvis dual phase, or I will say CT abdomen and pelvis pancreatic protocol, or you need to tell CT liver, which is liver protocol. So you need to be very, very specific in what you ask. This is what is this exam, or that's what I'm telling about this structured response. Yeah. Saiful?
Thank you.
Mr. Manikandan, thank you very much for your nice presentation, actually. And again, thank you for helping us to overcome this tough journey, actually. So my question is that one of my colleagues passed last exam, and he was the your trainee as well from PrepMedico, but he was the colorectal trainee, but his long case was breast.
Yeah.
So
Yes.
my question is that in the exam, does the examiner know that I am the colorectal trainee or I am the breast trainee? Is the examiner know or not know?
The examiner will know, because if you see the mark sheet, you will be given the name followed by your specialty. That is how the answer sheet, where the evaluation sheet will be provided.
Yeah.
But as I told, see, what is expected here? This is an FRCS general surgery exam plus your specialty. As a general surgeon, if you are sitting in a district general hospital, okay, you get any patient with a breast lump, you can get a patient with peripheral vascular disease, you can get a patient with dysphagia. Okay, so you should be able to get the proper history. You should be able to come to a diagnosis. That is what is expected. So if you have a breast patient, you should have a knowledge up to what history you will get, what blood test you will do, what investigations you will do, what are all the differential diagnoses. From that point until the point where this patient is referred to a breast MDT or an upper GI MDT or a breast surgeon, you should be able to know. Sometimes they had gone even beyond. That is why I have changed this numbers. Although in a breast surgery, the knowledge required is ST4. In the same exam, the particular patient, the history which they gave was patient had some bilateral flaps, bilateral mastectomy, previous radiotherapy, recurrence and stuff. So the level of question, although they say it as ST4, they go up to ST5 and ST6 actually. Yeah. So you should be able to know some basics about flaps in breast surgery. You should be able to know what investigation you will do in a male breast cancer. You should be able to know what are the problems with breast implants. You should be able to know what investigation you will do in a patient presenting with breast recurrence or cancer recurrence. So that level of knowledge is definitely needed. That's why I told in upper GI and colorectal, you should have ST7 knowledge. In all others, in transplant, including transplant endocrine, you should have ST5 to ST6 knowledge. The last exam, they had a patient where a patient presented with upper GI dysphagia, leading on to discussing about all the cancer and operations of the upper GI. They discussed about squamous cell cancer of esophagus. They discussed about adenocarcinoma. They discussed about the G junction tumor. Everything they discussed. Okay, but what is essential is you should know and knowledge up to a point where you make the diagnosis, and then you refer. If you don't make the diagnosis, for example, another serious thing which I forgot to mention is many candidates who come out of the exam telling that they have done fantastically. They have done fantastically. They will tell that, oh, I'm 100% pass. Then if you see the mark sheet, they will miserably fail. There are two common reasons for that. One is, as I told, each scenario, for example, if it's a 5-minute scenario, the examiner would have thought to ask you 7 or 8 questions, but you would have answered only 2 questions. According to you, you had answered those 2 questions perfectly, but the actual situation is you have not done more than 20% of that scenario. So that is one reason for people failing, even though they think that they're doing it right. The second important thing is, however good you do in a particular scenario, if you do something which is a serious harm to the patient, you will fail. It's exactly like a UK driving test. You do so many small mistakes, doesn't matter. One major mistake, you fail. For example, the same breast scenario, This patient comes to you, you do something, okay, you examine the patient, you get the history, and say patient has some lump or something, you assume that it is benign, and you tell that I will follow up this patient after 3 months, something like that. Actually, this patient should have been referred to MDT or something like that. Then it is a huge problem. Okay, for example, last but the previous exam, I had the exam, there was a sarcoma scenario. Okay, there was a thigh sarcoma scenario, and the biopsy results of the thigh sarcoma, they told it as atypical lipoma. Okay, that was the biopsy result. And many candidates whom I spoke, they told that this is an atypical lipoma, and they told that few told I will operate, few told this is a lipoma, if patient doesn't have any problems, I won't operate. And few told that they will do a radical resection by themselves. Okay, so obviously all these three responses are a serious harm. So you are missing a cancer in a patient, or you are mismanaging a patient. So if you assumed as an atypical lipoma as just a lipoma, and if you have discharged this patient, then you are failed in that session, because an atypical lipoma could be a sarcoma or anything. Okay, so that is a serious fail. However good you have done in the entire scenario, this one answer can fail you. Second important thing, someone told me that this is an atypical lipoma, so I will resect by myself. Okay, again, that is a serious harm to the patient. Okay, if you do something which you have never done in your life, okay, that is a serious harm. So this atypical lipoma could have been a sarcoma, and this particular surgeon who has never touched a sarcoma is operating on this patient, so he fails in that scenario. Or the third thing, someone says I will do a radical resection, although he has never done in his life. Again, that is a unsafe situation. So you should be very, very careful in the exam, making sure that you don't tell any unsafe answer in the exam. That's the most important thing. Again, that comes only by practice. Some practice, someone critiquing you, someone telling you what you are telling right or wrong. Okay, does that answer you, Saiful?
Thank you, boss.
Yeah. Any other questions from others, guys? If not, let us move on to the scenarios, so you have even more a better understanding. No? No questions from others? Good. Right. Let me.
Can I ask
Yes.
what's probably the best answer to for that atypical lipoma, please?
Oh, okay, like that. So what I would say is, if the biopsy comes as atypical lipoma, I would say I am concerned about the situation, because atypical lipoma could be anything. It could be a sarcoma, or it could be a liposarcoma, or it could be a lipoma. Again, it depends upon the site of the biopsy. Because it's a huge lump and they have taken a small biopsy from some point, it could still be a sarcoma. So what I would answer is, I am concerned about this situation. As per the NHS sarcoma guidelines, any lump which is more than 5 centimeter needs to be discussed in the sarcoma MDT. I will refer this patient to the sarcoma MDT to get their output. This is the answer you will tell. Then the examiner will tell you they have discussed in the MDT and they had advised to do an excision biopsy and plan further. Then patient comes back to me. I would say that yes, okay, so if that is the outcome, I am not skilled, or I don't have much experience dealing with such big lumps in the groin area. So I would either discuss with my colleagues who have expertise in this, or I would involve my plastic surgeons to see whether they would contribute. If I don't have any expertise in my hospital, I would refer this patient to the place where expertise is available to do this as an excision. This is what you need to answer. Yeah.
Thank you.
I have a question
Yes.
also, if you don't
Yes.
mind.
Yes.
It's again mainly for the short cases. You've mentioned that maybe the examiner having 7 or 8 questions for you, but maybe you've taken much time in answering one first or 2 questions, then the 5 minutes finish, and then there's maybe 5 questions you haven't been asked. Then you will fail. So what is the smart way to answer the questions in order to give him a chance to ask whatever he wants?
The smart way is, again, it comes by practice. So from the question itself, you as a trained candidate for the Section 2 exam, you should be able to know what the examiner is trying to get out from you. Okay. For example, simple thing. You have a patient who's presenting with an obstructed sigmoid colon growth, and the CT scan is showing liver mets. Okay. What will you do? This is a scenario. So you should be trained in your mind to know that, okay, this examiner is going to ask me questions like whether I will do a diversion or not. I have to, what will be the patient's discussion to come to a conclusion, whether it is just a palliative treatment or not. Or he might be asking me about liver first approach or something like that. So you should be able to know what is this particular session is about and what the examiner is going to ask from you. This should be the first point, so that you can prepare your answers. So you won't be, when I say prepare your answers, you should not waste time in simple things like I will get focus history from the patient, do this. So all the short cases, the purpose of the short case is to test your decision making. It is not to test how you evaluate the patient. That should be the first thing. So I would say, I am concerned about this patient. I will go get a focus history involving this, and I will move forward from that. So the first answer should be very, very quick, and you straight away jump from introducing yourself to a point where you go to a decision making. Then the examiner will tell you, okay, this. Many times, again, in the exam, at least 95% of the examiner will help you. If you are going slow, the examiner will stop you. Okay, stop you, and they'll move on to the next question. Because it is their responsibility also to make sure you move on to the next questions. But if you're so adamant that you don't want to follow the examiner, okay, and if you don't follow the examiner's prompt, then the examiner will just leave you and he will tell, okay, let him answer whatever he likes, I'm going to fail. Okay, the key points in short answers is, you should have in your mind that at least there will be 5 to 7 questions in each scenario. That should be one. The second thing is, all your answers should be quick and short. You cannot be answering a question for more than 20 seconds. 15 to 20 seconds should be a particular answer. This is how you need to answer and obey the examiner's prompts. Many times, when you're answering a long response, okay, the examiner will stop you bluntly and move to the next question. Okay, so some candidates misunderstand this, thinking that the examiner is irritated because you're telling a long answer. Some candidates mistake it as thinking that you are telling a wrong answer. Okay, and some candidates mistake that the examiner is so rude that he's stopping me answer. Yeah, that is not so. Okay, here the examiner is trying to help you. The examiner is trying to help you, telling that, dear man, you are answering so long, you need to stop here because we have 15 questions to go. So many times candidate will get offended. When the examiner stops you straight away, they get so offended, and that will reflect on their poor answer following on. They think that the examiner is so rude and they get so anxious and stuff. So the examiner will help you, but you should understand the examiner's prompts. So there is no tips and tricks or very secrets here. When you do practice, when you do this short case practices, you will know what you need to tell and what not. Yeah. Any other questions, guys? No? Right. I think we have spent already 1 hour. Let us move on to some scenarios. Okay. So who wants to answer the first? You raise your hands. Whoever wants to answer, you can raise your hand so I can keep it in my queue and I can call. Whoever wants to answer, you can raise your hands. Okay. Right. Let me start with Alia. Are you here? Would you like to switch on your camera, or you don't want, Alia?
I don't want.
Okay, you don't want. That's fine. Don't worry. But that is only for now. I know you have registered for the course, and the course it will be very, very strict. Okay, no
Yeah,
switching
okay.
on camera, no answers. Okay, because as I told, most of these courses, whatever we do, we try to replicate the actual scenario, but because it's all virtual, unless you assume yourself that you are sitting in front of an exam, that actual practice doesn't come in. That's fine. Don't worry. Okay.
Sure.
Let us have a general surgery discussion, Alia, for you. Okay. So you have a 45-year-old male coming to your general surgery clinic. Okay. Patient is referred by the GP because a patient has been having constant upper abdominal pain. The GP had treated this patient with some PPIs, but the patient's pain doesn't settle. So patient is coming to you. How will you approach the situation?
I'll start with first the history of the patient. I'll ask for the age of the patient and more detail about the symptoms of the patient. When is the pain? When the pain starts, is it related to the meals or not? It comes on empty stomach or full stomach? And what are the aggravating and relieving factors? Does it radiate anywhere or not? Then I'll ask him, does he has a history of heartburn, any associated melena, hematemesis, weight loss, previous history of such pain?
Mhm.
So,
Fine. So you had asked all these things from the patient. Patient says that patient, as I told, is a 45-year-old male. Patient doesn't have any comorbidities. Started having this upper abdominal discomfort 3 years before, and the discomfort is becoming more and more bad. Okay. Patient occasionally has heartburn, but nothing much. And there is no obvious aggravating or relieving factors.
any postprandial heaviness?
No,
No weight loss.
no weight loss,
Any history of jaundice?
nothing.
And what was the treatment given to the patient?
So patient had seen the GP. The GP thought patient has some gastritis, so he has given some PPIs, which never helped.
Which never helped at all. There is no associated nausea, vomiting, fever.
Nothing, except for occasional, reflex symptoms.
What is the BMI of the patient?
Patient looks very thin. You have to examine. You have to take those details. Patient doesn't know what's the patient's BMI.
What's the patient BMI? So if I will examine the patient, I will look for any signs of anemia, jaundice, and
Mhm.
physical build of the patient.
Mhm.
I'll go for weight of the patient, vitals, and then after all this, I'll go for the examination of the abdomen.
Okay, so you examine the patient. The general examination is absolutely normal. He's fit and well, no pallor, nothing. And you
So
go
then-
ahead and examine the abdomen also. The abdomen is slightly distended, some tenderness in the epigastric region. The rest of the abdomen is normal.
normal. And PR examination is normal as
Yeah.
so. Keeping in mind the patient symptoms, still the diagnosis is not very clear. It could be gastritis, could be gallstones.
Mhm.
So I will go ahead with some blood investigation,
What some
and
blood investigation you will ask for? What some?
I'll for full blood count to see for the hemoglobin of the patient,
Mhm.
and I will ask for amylase and lipase
Mhm.
to rule out pancreatitis.
Mhm.
And I will see the patient electrolytes because he has been having pain for so long and not eating well. So just to look for any electrolyte imbalances,
Mhm.
and as well as the liver function tests and the albumin of the patient.
Fine. Right. So you do blood tests. All the blood tests are the basic blood tests are perfectly fine, normal.
Okay, so I will ask for an ultrasound abdomen.
Mhm.
Mhm.
Okay,
To
so
rule out.
you do an ultrasound scan. The ultrasound scan comes back as there is a large 20 cross 15 centimeter cystic lesion in the epigastric region, unable to identify the source of the sedation.
And it was not palpable on clinical examination.
No,
Yes.
no. There is some fullness, but there's no obviously palpable.
So if it's like that, I will go for a CT scan of the abdomen with contrast. Just to
What contrast? You want oral contrast, rectal, IV, what contrast?
oral and IV both.
Why do you want oral?
To see any bowel related relationship of the mass,
Mhm.
and also to see whether mass is causing any obstruction or
Okay.
not.
When you say IV, what phase of CT scan you want? You want the arterial phase, venous phase, delayed phase? What phase you want and why?
Venous phase
You don't
and
want arterial phase?
arterial and venous both actually. Yeah.
Why do you want arterial phase? What's the problem? So normally when you ask a radiologist telling that I want a CT scan with contrast, okay,
Yeah.
what phase they take normally?
What phase we get normally?
Yeah.
Now we get arterial and venous both, and delayed venous phase as well.
Is it so?
I
Is
think
it so?
so.
What is the problem? What is the problem in taking all these phases for every patient? They generally, whenever you ask for a CT scan with contrast, you will get only CT scan with venous phase. There are multiple reasons for that. One is because venous phase is the best phase to pick up most of the diagnosis. And second thing, again, lesser radiation. So every phase you expose patient for one cycle of full radiation. Yeah. For an arterial phase, patient goes in and comes out. For a venous phase, goes in and comes out. For a delayed phase, he goes in and comes out. And every time he goes in and comes out, the amount of radiation is extreme. So you should be very, very clear on the indication of exposing this patient to this radiation. Also, the volume of contrast which we use for a single phase to a triple phase is completely different. Yeah. So unless you specifically ask whether it's a pancreatic protocol or a triple phase protocol, you will get only a venous phase CT scan. Okay. Good. Fine. So you have done, you asked for a CT scan. And again, this is not something which you decide. If you decide, that is good. But normally, the radiologist should be able to identify or decide what protocol you need. That is why we call it as protocoling the CT. Instead of you requesting and the radiographer doing it, you request and the radiologist will protocol the CT scan. They will see what is your question. Depending on your question, they decide what CT scan they want to take. Okay. Right. So this is the CT scan. I'm showing the CT scan.
I can't see still.
It's still flying in, coming in. Yeah. Right. Can you see now?
Yes.
Yes. Can you read the CT for me, please?
How can I enlarge it? Yes. Okay. So this is the CT scan abdomen of 45 years old patient, venous phase, which is showing a large cystic swelling in the left hypochondrium, and it is compressing the stomach.
Yeah, tell me.
Yeah, and actually,
you told it's a venous phase. Is it a venous phase?
It's a venous phase. Yes.
What is this here? This is the aorta, isn't it?
Yeah.
When the aorta is bright, is it a venous phase or an arterial phase?
It should be arterial phase. Yeah.
It is not, it could be, it is an arterial phase.
It is
It's an arterial phase, but obviously this image, we don't know what phase it is. It could be a venous phase also, we don't know. Okay, but okay, fine. So what do you see here? Large cystic lesion, what?
Large cystic lesion, it could be, I cannot make up on the basis of only one scan. Either this is related to the stomach or it is some mesenteric mass that is compressing, because I can see medially compressed bowel structure, but I'm not sure whether this duodenum or stomach. And
How can
what
it be a mesenteric cyst there? It's in the left hypochondrium, isn't it?
Left hypochondrium.
Okay, what else it could be? What cystic lesion can arise from a stomach? Is there any cystic lesion which you could think of which can arise from stomach?
Stomach. Simple cyst in the stomach, I have never heard of.
Exactly, no one has heard of actually. What else it could be? Okay, so this patient is coming and sitting in front of you with this CT scan. What are you going to do now?
I will go and see more cuts and discuss the CT scan with the radiologist. And based on the findings.
No, wait. I am your radiologist. You ask me what answer you want.
Yeah. I just want to see where is the origin of the cyst from.
Okay, so I am telling, oh, this is a 16 cross 15 centimeter cyst arising from spleen.
Spleen. Okay.
What other questions you want?
I just want to ask, is there any peripheral enhancement? And there is any active bleeding in the cyst? And the consistency of the material within the cyst. And I will also ask to see whether is it contributing to the features of the hydatid cyst or not.
Okay, fine. So I am your radiologist. I'm telling that this is a thin-walled cyst 15 cross 16 centimeters, homogeneous with no septations.
Mhm.
Okay.
Yes.
Possibility of a cystic lesion of the spleen, query simple cyst, query, pseudocyst, query chronic hematoma, etc. How are we going to deal this now?
Yeah, I'll just and the consistency is that of water or
It is homogeneous. It is more of a cystic. Yes.
more of it? And I'll just clear that the adjacent structures like pancreas and stomach, they are clear and it's well defined.
Yes.
Yeah. So since patient is symptomatic and after having finalized decision from the radiologist that it is simple cyst, since it is vague and patient is having cyst symptoms, I will go for aspiration of the cyst.
What are all the differential diagnoses of the simple cyst? Why does a simple cyst come in spleen? What could be the reasons?
It could be either because of just simple cyst, or it can be because of previous history of trauma, and
Mhm.
can be hemorrhagic cyst. It still can be a hydatid cyst as well.
Mhm.
Unlikely to be malignant.
Mhm. Okay, so if you tell that it is still could be a hydatid cyst, yeah,
Mhm,
and you are going and aspirating it, is it?
mhm.
Are you not causing a serious harm to the patient? What if
Actually,
patient develop anaphylaxis and dies on table?
if I will think of the hydatid, then I'll go for the blood investigations
No,
related to the hydatid.
do you think hydatid cyst in this patient or not? Well, it's not about if. In this patient is in front of you. This is the CT report. How will you proceed?
According to whatever we can see in the CT and we discuss with the radiologist, it has no features of the hydatid because
So
there
what features of hydatid cyst you are looking for?
for this, no, I will not. I will say this is not hydatid cyst because I have
Why?
already discussed with the radiologist because
Why?
because there are no calcifications, there are no daughter cysts, there are no membranes in it, so the criteria doesn't meet of that of a hydatid cyst.
What is in Garby's classification type 1?
I don't know.
Yeah. So if you see hydatid cyst, the type 1
Mhm.
and type 2 cysts are unilocular cysts.
Okay.
Unilocular cyst, and they don't have daughter cyst, they don't have calcifications, nothing.
Mhm.
Any cyst can be a hydatid cyst. This could be a hydatid cyst. Okay.
Okay.
So what is the
Mhm.
commonest cause of a cystic lesion in the spleen? What is the commonest cause?
Commonest cause congenital.
No. First cause is traumatic. The second
Mm-hmm.
commonest cause is a hydatid cyst. Okay, the
Hydatid
second
cyst.
cause. Then comes all the congenital cyst and stuff.
Mhm.
So you were planning to operate, and I am your colleague. I am telling you, you cannot be operating this case. What if it's a hydatid cyst? I'm telling you. What will you do now?
If it's hydatid, it's still we can go for pair procedure, but I think the size is a little bit bigger for it. So first we will go for IHA titers and see if it is patient is acutely infected, and we'll start with medical management just to control the infection in the cyst. And while we go for
So
laparotomy,
when you
we
say
can
IHA, you mean the hydatid serology, you mean, yeah?
yeah,
Okay, so you do a hydatid serology, and hydatid serology comes as positive. Yeah. What next? What are you going to do now?
it's like IgG positive or IgM positive.
It's IgG positive. IgM is negative.
Negative. So it shows that a patient has chronic infection, but since there is a patient did not give any history of previous medications and it's still patient is symptomatic, I'll start with the medical treatment first. I'll involve the
What
medical.
medical treatment?
It's usually albendazole, and
Mhm.
for the treatment, I'll involve my medical colleagues and
Mhm.
ITU colleagues to start the treatment for the
What
patient.
what is the aim of giving this albendazole now? What is the aim?
It's to make the like cyst inactive so that
Okay,
there
okay,
should be no
fine.
active infection.
Right. So you gave for 3 months. What next?
After giving the 3 months, I will again assess the patient regarding the symptoms and repeat imaging as well. And if it is still the size is same, patient is symptomatic, we'll proceed for surgical intervention.
What surgical intervention you want to do?
And we will go, first of all, we will consent the patient,
Yeah,
and
that's fine. What surgery?
surgery is we can do cystectomy.
What cystectomy you do in spleen? You just mean the deroofing the cyst, you mean?
Hello?
You mean deroofing the cyst, yeah?
Yeah, deroofing the cyst under control, and then we can aspirate.
Mm-hmm.
After aspiration, we will just under controlled aspiration, when we have aspirated the cyst and everything, we can just either cover it with the omentum, or if
Mm-hmm.
possible, and we can take out the pericystectomy. If we can do, we will take out the cyst together.
You mean you'll do a partial splenectomy?
As far I did not discuss with the radiologist, but as far as I can see, the spleen looks it looks to be originating from one part of the spleen, and the rest of the spleen
Mhm.
looks suppressed. Yeah.
Mm-hmm. Okay. What else it could be? How do you know that it is not? Let's imagine this patient had a pancreatitis in the past. How do you know that it's not pancreatic pseudocyst?
What image I can see on the CT scan looks like that the pancreas is well defined and is at its normal position. Doesn't look like to be originating from the pancreas.
Mm-hmm. So pancreatic pseudocyst never arises from the pancreas itself, isn't it? It is a fluid collection in the lesser sac, isn't it?
A lesser sac, but definitely, but the origin is related to the pancreas. You will not see the pancreas that smooth with outline and echo texture.
Oh, sure. In an acute pancreatitis setting, yeah, and you have an acute peripancreatic fluid collection, and in over time, in 2 to 3 weeks, the pancreas inflammation will settle down, but you'll still have fluid around the pancreas, isn't it? So this could still be a pseudocyst of the pancreas. Sometimes the pseudocyst can be ruptured into the splenic capsule also. Okay, so you need to think about everything. So I'm going to stop here, okay, because we have answered very well. But excellent attempt. Okay, let me tell you few good things first of all. Yeah, you have a very confident way of answering, which is very good. Your language skills is very fine. So although I have not seen your face yet, but I can tell you that you have a good experience on managing a lot of surgical patients, and your answer means your attitude is quite very confident, which is very, very good. Okay, coming on to the exam critic and viva technique. Okay, so this patient, again, this should be a short case in your exam, but don't worry about whether short case or small case. How I would have approached differently is, when this patient comes in, I would say that I would get a focus history from the patient. Yeah. And of course, you told everything. I don't mind. Yeah. And then at the point where an ultrasound scan showed a cystic lesion in the upper abdomen, I would have told a cystic lesion in the upper abdomen, my differential diagnosis are, first of all, I need to know what is the anatomical origin of the cyst. It could be a big cyst from the left lobe of the liver. It could be a pseudocyst of the pancreas. It could be, a big cyst in the kidney, upper pole of the kidney. It could be a cyst in the spleen. So in order to further characterize this cyst, I would like to do a CT scan venous face with IV contrast. Okay. And in the IV contrast, this CT scan, you should have picked up, when you told a point where this is a cyst arising from a stomach or something else, that is a serious threat for your knowledge. Yeah, that is what cyst you expect from the stomach. As I told, common things are common. Okay, you cannot be thinking of rare diagnosis here where you have 1 in a million incidents or some cystic lesion in the stomach. So what common things which can come in this region is either a pseudocyst of the pancreas or it could be a splenic cyst. That is the most common things. So you tell these, okay, and then you need to tell, okay, this is the finding. You need to tell, I would like to discuss with the radiologist to confirm. So in the exam, the purpose of showing this image is to test your knowledge in reading the CT scans and the SPECT scans, PET scans, etc. But at the same time, you need to answer very, very safe. You need to tell what you see here. And even if you have a very clear diagnosis here, okay, for example, you have a gallstone and you see a stone there, still you would tell that I would still discuss with the radiologist to make sure I am not missing anything and to confirm the diagnosis. That is how you play safe. You tell that. And then to the radiologist, when I asked you, I am your radiologist, you ask whatever questions you want. You need to tell, I want to know the anatomical origin of the thing. Second thing, I want to know whether it's a simple cyst or a complex cyst. And the third thing, which you all told, actually, you told what is the cyst characteristic, which is very, very good. Okay. From that point onwards, so there's a cyst in the spleen. Now, you have a diagnosis in your hand, you have a cyst in the spleen, patient is symptomatic. So you need to intervene. First of all, you need to decide whether you need intervention or not. Not all cyst needs intervention. Because this patient is symptomatic, you tell that, okay, I will discuss in a benign MDT if you want, or you can decide that given that the patient is symptomatic, I would like to intervene this patient. But before intervening, I want to make sure that I am not dealing with the hydatid cyst. I am not dealing with the pseudocyst of the pancreas. So hydatid cyst, you do a hydatid serology. And for a pseudocyst of pancreas, of course, you can test the, the pancreas and stuff and get the history from the patient. But if at all, if you aspirate this fluid for some reason, okay, make sure you send the fluid for amylase. That's the most important thing which I want to ask you. Okay. Again, this is a case of actually a unilocular hydatid cyst of the spleen, actually. Yeah. And the treatment is, you will be asked about why you need to start on albendazole, when will you give mebendazole, what are all the problems with albendazole, how will you advise the patient to take albendazole, whether it's empty stomach, morning, evening, and things like that, what test you will do on patients with albendazole, and then what intervention you will do. So you need to pick up that a cyst in the spleen is quite very rare, and hydatid cyst in the spleen is quite very rare. So I may not be dealing this patient. I would refer to the HPB surgeons. Okay, unless you have expertise, you are not going to do it. See, if you want to do a splenectomy here, that is fine. If you have never done a hydatid cyst resection in your spleen, you should not do this. You should refer this patient to a HPB surgeon. And the options available are either you do a total splenectomy, or you can still do a percutaneous pair technique. You can still, because it's a unilocular cyst, this is an ideal situation for you to do a pair percutaneously. Yeah. Here you can do a laparoscopic cyst deroofing and things like that. But again, you need to tell what you will do based on your experience and based on the patient situation. Okay. But overall, you did very well. Yeah.
For the pair technique, is the size criteria what I remember? I did not revise.
No, it is. There is a 5 centimeter size criteria, but again, not means everything. There's no black and white for most of these things. So here you need to weigh the balance between. So many times when you say, unlike liver, where deroofing the cyst is much easier and the bleeding is less compared to spleen. In spleen, if something goes wrong, you need to take out the spleen. Yeah. As much as possible, if I am the consultant in this situation, and if it's a symptomatic cyst, as much as possible, I would like to do an intervention which doesn't threat the spleen. Okay. So in that situation, I would prefer to do any less invasive procedure if possible. And if that doesn't function, move next. Because unlike liver, here, even a slightest of a problem, you have to do a splenectomy at the end. Yeah. Which I would try to avoid. But you won't be wrong if you tell that the pair is an option. However, the size of the lesion is quite very big for a pair. But still, I would discuss with the intervention radiologist to see whether it is feasible or not. Okay. So again, the way you should answer is to make sure that you do your best to give the best to the patient. That is what you need to tell. Yeah. And but you did very well, actually. Yeah. Any other questions from others? Yep. No? Right. I'm not going to waste much time. Let us move on. If you have any questions, stop me, guys. Okay. Right. Spurti.
Yeah.
Hi, Spurti. Where are you from? When are you giving your exams?
I'm from Maidstone with breast specialty interest, and my exams part 2 is in September.
Oh, good. Okay, fine.
Yeah.
Right. Good. Right. Okay. So imagine you are the consultant on call and you have a 60-year-old male who is a child C cirrhotic patient, secondary to chronic alcohol-related liver disease, coming to you with a strangulated parumbilical hernia. How will you approach the situation?
Okay, so he's a child cirrhotic patient with umbilical hernia. So my first thing would be to see how is his liver function, and also my suspicion would be it's probably ascites-induced umbilical hernia as well. Keeping this in mind, I'll take a focused history from the patient regarding his liver condition. How long has it been? How long has he been diagnosed with a child's liver cirrhosis? What's the plan from the transplant team? And regarding the umbilical hernia, I'll check how long has noticed a lump, any associated pain, has he opened up his bowels, any fever, has he noticed any signs of infection, redness over the lump?
Fine. So this patient says that patient is known to have alcohol-related chronic liver disease, and he continues to drink alcohol. He has never met any liver transplant team or anything, but he is under a hepatology care who is advising them, and patient is under some de-addiction program. Okay. And patient has been having recurrent decompensations in the form of ascites. Several times he had an ascitic tap done, and he is on diuretics. He never had an hematemesis in the past. Okay. And this pain, he has been having some paraumbilical swelling for a few years, but since last 2 days, he has a very tender swelling in the paraumbilical region, and it's very painful.
Okay. That worries me a bit because for the past 2 days, there is tenderness and it's very painful. So I'm thinking whether it's a strangulated paraumbilical hernia. I'll check with him if he has had any surgeries through the umbilical area.
No.
No. Okay. And I will also check regarding his symptoms, whether he has passed whether he is vomiting, whether he's opened up his bowels, is he able to pass flatus, any signs of obstruction, any symptoms of
This
obstruction.
patient says that patient has been vomiting for the last 2 days, unable to eat, and he opened his bowels a week before.
Okay, so he is obviously an obstruction, and it is quite. I will examine the patient next to see his current status of ascites. I will also do a general examination to look at his jaundice, any edema, pedal edema, any signs of liver. I mean, he may have signs of liver cirrhosis clinically as well. And on examination, I'll also examine the hernia to see if there's any signs of redness, infection, cough impulse to see and confirm if it is a paraumbilical hernia. And
the patient is jaundiced, okay, and you see that he has moderate to massive ascites clinically, and has a very tender paraumbilical swelling.
Okay, so I am worried about obstruction at this point, and of course, the second thing I'm worried about is child 3 cirrhosis and his fitness for surgery if he needs surgery. So I will do a routine investigation first. First, check his vitals, blood pressure, pulse rate, fever, pyrexia, and then also check send his bloods for routine bloods. Also recheck his liver function,
So
clotting time.
what would you like to check in the routine blood tests?
So I will check for his liver function, bleeding time, clotting time, INR, and
so patient's
from the
platelets is 60. What does it mean? What does it tell you?
Platelet 60 could be due to his cirrhosis itself.
Why cirrhosis should cause thrombocytopenia?
By reducing the clotting. No, it shouldn't. I'm not sure. But platelet is
in a chronic liver disease patient, yeah. What does a platelet count tell you? What is the platelet count a marker of?
Is a function of spleen.
Okay. But what does it tell you?
His bleeding status and his clotting status and his hemostasis.
No.
And
it tells the degree of port-life tension. Okay.
Yeah.
The platelet count tells you the degree of port-life tension. Right. Okay. So you do your full blood count. Okay. Patient's platelet is 60. Okay. WBC count is 22,000. Okay. Hemoglobin is 86.
Okay.
Okay. Liver function tests are quite deranged. Okay. ALT, ASTs are in 100. Bilirubin is 75. Yeah. Okay. Alkaline phosphatase is also high. Okay. INR is 1.8.
Okay.
Okay. Patient has acute kidney injury. Okay. Grade 1 acute kidney injury.
Okay.
What next?
So I am worried about any systemic inflammatory response syndrome with his current liver and kidney injury.
Why systemic inflammatory response here?
There's 2 organ dysfunction with WBC increase and liver function increase.
Okay.
But of course, I will manage him initially with the conservative management, nasogastric tube, IV fluid resuscitation, antibiotics, vitamin K to help with his INR. And I will also do a CT scan next if the patient is stable.
Patient is stable. Patient is hemodynamically stable. Patient's acute, it's grade 1 acute kidney injury. Would you like to do a CT or not?
Yeah, there's a risk of contrast injury, contrast-induced nephropathy if I'm giving a contrast.
Is it? What does the recent evidence say? I told it's a grade 1 acute. So yes, it has a huge
It can
impact
worsen.
if patient has a grade 1 chronic kidney disease. Okay. In acute kidney injury, giving a contrast doesn't have much role. It doesn't increase your incidence of developing an irreversible kidney damage. No. Okay. But why do you want a CT scan? What does it tell you?
I want to check if there's obstruction and strangulation, any sign of bowel ischemia.
That is clinically you can see, isn't it? Patient has a very tender swelling. Patient is vomiting.
I'd also
if
like
the CT didn't show that? What if you do a CT scan and you see bowel which is there in the hernia? There is some dilated bowel loops proximally. How does it going to change your management?
If there's a sign of ischemia and strangulation, then I would consider surgical approach if the patient is fit and if the patient is not responding to the conservative management.
We are in this patient. You are at 11 o'clock in the night, consultant. This patient is in the A&E. Okay. So this patient, do you think patient is fit?
He is in the A&E, so he's obviously not very fit.
No, when I say that is
but
not,
also has a history of liver.
Imagine you have a 16-year-old boy coming with acute appendicitis to A&E. Will you not tell that he is not fit?
16-year-old boy is fit, but in his case, he has liver child C cirrhosis.
Yes, of course, he's a very high risk patient. Yes.
Yeah.
Okay. So what will you do now?
I will discuss with the patient and what is my diagnosis, that it is probably an obstructed parambilical hernia, which could be aggravated from his liver child C cirrhosis, ascites causing more pressure. And in his case, he is symptomatic, his counts are high, I'll discuss surgical option with him, but at the same time I will also discuss with my anesthetic colleague to see if they're okay to proceed with this surgery.
How does an anesthetist tell you? What does anesthetist is just going to anesthetize the patient? I am your anesthetist. I am telling you that you decide, Dr. Spurti, if you want to do, I'm happy to anesthetize.
So he is obstructed umbilical hernia, so he will need a surgery. I'll discuss with the patient regarding open surgical paraumbilical hernia. I will explain to them about the recurrence of hernia is more. There is a chance of recurrence with his ascites, which can cause recurrent hernia. But current aim is to relieve him from the obstruction, which is what is bothering him and which is what is presenting symptoms. I will explain him that regarding the surgical procedure, and will also I'll also maybe keep some FFP standby if there's a risk of bleeding due to his high INR. If he has deranged bleeding during the surgery, I'll explain the patient regarding all the risks involved with the surgery, and the aim is to correct his obstruction. And
patient says, okay, fine, doctor.
Okay. So I will list him up for surgery. I will discuss with the team, brief the team on what's the plan.
Okay, so you told that you want to do a CT scan before. You would like to do a CT or you don't want to do a CT?
I would like to do a CT to just confirm if there's anything.
Confirm what?
mean, confirm the diagnosis of paraumbilical hernia, even though it is clinically there, maybe to confirm the content, whether it's a omentum or a bowel, but he has obstructions, is likely a bowel.
What else you as a surgeon? So you are the surgeon who is going to operate on this patient alone in the middle of the night. Okay. So you are discussing in a way that you are discussing like any other patient with a paraumbilical hernia. Okay. So whatever answers you told won't be different. If I have given a fit and well patient with a paraumbilical hernia, you would have told the same answer. But this is a very, very special situation where you have a very, very high risk patient who can have various problems, but you have not given any importance to any of these things. Yeah. You want to answer differently anywhere?
Because of his child's cirrhosis, I will discuss with the hepatology, HPB team to see what they would advise regarding his liver. Sorry.
What do you think they would advise? What do you think operating on this patient? What's the problem?
He has a lot of he has a lot of issues concurrently together with paraumbilical hernia, and it's portal hypertension. All that needs to be corrected. His platelets needs to be corrected as well. He would need a transplant ideally, but because not now, but he was a candidate.
You're gone to a different place. You are killing yourself. Come back. Come back. Come back. So when I say what do you think is you have a child C patient. Why are you worried about child A, B, C? What does it tell you?
He's decompensated liver function, so he's quite. It's a severe kind of liver failure.
Okay, so at least it tells you the grade of liver failure. Okay.
Yeah.
So child C is severe grade of liver failure. Okay.
Yeah.
What does it? So in a child C patient, what you could do and what you could not do. So first of all, why did this child scoring came? First of all, why did they devise such a scoring?
To categorize patients' severity of liver failure and then decide
and what
management of.
No. If you see in your traditional undergraduate level studies, child A, the surgery risk is 30%. Child B, the risk of death is 70%. Child C, risk of death is 100%. Okay, this is, you will see this table. Okay, so child score was basically devised to categorize the chronic liver disease for patients undergoing shunt operations. Okay, the child score will tell you what is the risk of a patient dying secondary to a shunt operation in a patient who bleeds. Okay, so child score is devised to tell what is the post-operative complication. Okay, but in this situation, but it is only for the shunt operation. It's not the same for a paraumbilical hernia repair or an inguinal hernia repair. So in this situation, I'm going to stop you here. Okay, I'm not going to stress you more. Yeah. So in this situation, this is a completely different situation. So if I was given this scenario, what I would say is this is a very high-risk situation. Okay, I'm concerned about the situation because this is a child C cirrhotic patient who is coming with a strangulated paraumbilical hernia. I will go and see the patient myself. I will, examine and resuscitate the patient based on the CRISP protocol. Okay, this should be the first line, CRISP protocol. I will get a focus history from the patient, asking about his liver disease and asking about his paraumbilical hernia. You stop there. The examiner will tell you. If the examiner wants to discuss the management alone, the examiner will tell you the whole history. Or if the examiner wants to check what you will ask the patient, the examiner will tell you, okay, you can ask whatever questions you want. Then you will tell specific questions about his chronic liver disease. You will tell what is the etiology of chronic liver disease, what kind of decompensations. You never told about whether patient had jaundice, patient had cancer in the past, patient had blood hematemesis in the past, whether patient had ascitic tap in the past. Okay, this is about the chronic liver disease. And coming to the paraumbilical hernia, what is it? And you need to check when was the patient's last endoscopy, whether patient is taking diuretics for the ascites and things like that. When it comes to the management, okay, so now you have a child C cirrhotic patient who is strangulated and this one. So this is not a common scenario where you decide on surgery straight away. So you need to tell that this is a surgical emergency where the only treatment option available is a surgical resection or a surgical intervention. But the things which I would consider is, first of all, whether I need to operate on this patient or not. That depends upon how frail is this patient. Child disease cirrhotic patient won't be very healthy. How frail is this patient and how bad is this liver decompensation? I would quickly review his last hepatology clinic letters to know how sick he is, and I would also quickly do a frailty scoring to see how frail is the patient. And you need to have a quantification. I would do a NELA score to see what is the patient's perioperative mortality risk. All these things you should have for you to substantiate whether you are making a right decision or not. Then you will go and explain the patient. Yes, you have this. I will explain the patient telling that this is the diagnosis. However, I will explain him that he is a very high risk patient given his chronic liver disease, his frailty, and I will explain his mortality risk based on the NELA score. Okay, and if the mortality is very, very high, I would like to involve my another colleague, or I will do an emergency MDT involving the anesthetist and intensivist to decide what is the right course of action. If the patient is very frail and if the patient say your mortality risk is 40%, and if the patient is very, very frail, even if the patient accepts that, insists you that he wants surgery, the decision is with yours. You can still tell that, no, I'm not going to operate because if I operate, I'm going to give you death by 100% and it's going to be a painful death. You can still palliate the patient at that point. Yeah. Even if the patient insists for surgery, I will do a quick MDT to check whether surgery is the right option for the patient. Once everyone has decided that it's the right option for the patient, again, you need to tell that I will do a NELA scoring. I will make sure an intensive care bed is booked for this patient. I would personally do a CT scan in this patient, mainly to look not for the content of the hernia. I would look to see what is the severity of the chronic liver disease, how bad is the portal hypertension, if there is extensive abdominal wall collaterals or not, how bad is the ascites, so that I can plan my surgery properly. Okay, that is why you do a CT scan. Also, I will also look what is the content, whether it is viable or not. That I will say. Then before taking this patient to theater, I will consult the patient, I will take to the next of kin, I'll do this NELA scoring, and then because patient's INR is 1.8, I will discuss with the hematologist to see if I need to give anything. Okay. If the hematologist is happy, the hematologist might advise me either to operate with an FFP and platelets in the back, or he might advise me to give Veriplex, but I would advise whatever the hematologist say. Then I will go for the surgery. And in the surgery, I will do as minimal as possible. I will do a quick incision, reduce the content, and I would not place a mesh. And I will place an intra-abdominal drain to drain the ascites, or else patient will have recurrence and will start leaking through the wound. This is how you need to answer.
Okay.
Yeah? Does it make sense?
Yeah, it's
You
all
need to be
structured and organized.
exactly. You need to be quite sequential. You need to be, you should not be going up and down and things like that. Okay?
Okay. Okay. Yeah.
Good. Any other questions from others here?
Was to
Anyone?
bother you. So,
Yeah, you tell me any questions.
yes,
This is
it's
the
Saif.
time yes.
It's Saif here, Mr. Mani.
Hmm.
I have a query regarding the landing answer during my first initiation. Say, for example, first patient upper abdominal pain. Can I tell examiner that I would like to take focused history to exclude some differential diagnosis like
Yeah.
upper GI pathology, hepatobiliary pathology, and splenic pathology as well?
Yes.
So
You can tell whatever you like, but it should express what all you're thinking in your mind.
Yep. Okay.
Yeah.
Thanks.
When I say express, you need to express how do you feel about the situation, and you need to express what are all the differential diagnosis running in your mind. Yeah.
Yeah. Thanks, boss. Yeah.
Good. Let me
Okay.
move on. Call
Yes.
Yes, Kevin.
Just when you mentioned about the child Q score, assess
Yes.
mortality for the shunt operation or for the any operation in general?
Actually, the child score, when it was devised, it is mainly for the shunt operation, actually.
Okay.
The child score is for the shunt operation, and the MELD score, do you know why MELD score was created? Hold on.
Is it for tips or?
Excellent, very good. So it is MELD score was created to see the risk following patient undergoing tips, again for bleeding. Yeah.
Okay.
Yeah, very good. Good. Right. So let me move on. Colton, you want to answer next?
I would love to.
Of course you can. How are you doing otherwise? You okay?
Yes, thank you very much.
Let me open. Right. Okay. So, hold on. So imagine you have a patient who is coming to your clinic with generalized, means chronic reflex symptoms and weight loss. Okay, you are in the general surgery clinic. How will you approach the situation?
Okay, so I introduce myself, explaining my name and position to the patient. And my name is Khaldun Nadi. I'm a surgeon seeing you today in the clinic. So can you first of all tell me what's your age and how did your problem started, please?
Okay, fine. So imagine the patient is telling you the full history. Okay, imagine that it's
Yes.
a short case for you.
Yes.
So the patient tells that patient has been having chronic reflex symptoms for a very long time. Okay, and patient has been taking PPI for a very long duration. Recently, patient started feeling, some discomfort on swallowing. Okay, some discomfort on swallowing, and hence patient has went to the GP, and the GP further investigated, and he also says that patient has lost like 3 kgs weight in the last 6 months. And with this background, patient has come to you, no comorbidities, nothing, fit and well patient.
Okay, again, I just want to double check the age of the patient, and this is serious condition which has been long standing. It sounds to be a complication of unresolved pathology and advanced presentation of important things here to rule out cancer situation. Of course, other differential in my mind, like benign situation, is also there. I need to know exactly the type of medication that he's taking. I need to know exactly if he's got any investigation done for him. If he had any, for
The
example.
patient has not had any investigation done so far. Okay, and patient has been taking lansoprazole for once in the morning for the last 7 years.
Okay, if there is any family history, if there is any of any upper GI problems,
No, nothing.
any, I didn't get the age, just
45 years old.
45.
Yeah.
45. Male patient.
Male, yeah.
Male, okay. I'd like to ask if there is any alcohol or smoking as well.
Very occasional. Social smoker, social drinker.
Okay. In general, how is his health? Like
He's fit and well otherwise, except for 3 kg weight loss in the last 6 months.
How much?
3 kgs.
3 kg.
But his appetite is normal, but he feels that he has some discomfort to eat.
Okay, so I will start with again with the history. I need to proceed to examination, general examination, check for anemia, for
Okay,
signs.
with the history, what are all your differential diagnoses?
Can be a complicated reflux disease. Can be due to hiatus hernia, can be due to stricturing disease of the lower esophagus, can be evolving into maybe an evolving cancer as well. For example, in the esophagus can be simply dyspeptic syndrome, which hasn't been treated.
That's fine. So you do do a general examination for the patient. General examination with patient is absolutely normal, and you do some blood tests. Blood tests are absolutely normal. What next?
I proceed for investigation step by step here, going into an ultrasound of the abdomen, doing and also OGD.
Ultrasound scan. Why do you want to do an ultrasound in this patient? What do you think?
Because one of the common presentation of gallstone disease is reflux.
Okay. So you do an ultrasound scan. Ultrasound is normal. Okay. You do an endoscopy. The endoscopy shows there is some significant reflux gastritis, reflux esophagitis in the distal and the G junction, and you see that the esophagus is dilated with food residues. Otherwise, the scope is easily possible.
So this gives me an idea of if there is any biopsies taken as well from the esophageal inflammation. This can give me also more information. I would
Unfortunately, they didn't do a biopsy.
Okay. Yes. From this, one of the other differential here is achalasia as well, because of this finding. So I will proceed because this differential has come in on the top now with the OGD finding. I will do um, radiological study.
What is achalasia cardia? What is achalasia?
Is lack of peristalsis in the gastroesophageal, loss of peristalsis of in the esophageal muscles with high failure of sorry, it is failure of relaxation of the lower esophageal sphincter.
Good. So failure of the legs, and what is the common reason for that?
It is not well understood the cause, but it is the background of loss of my enteric plexus that is its function to help in relaxing the lower esophageal sphincter when it is activated. So
is it loss of myenteric plexus or something else? What do you see in the biopsy, if at all, if you biopsy the lower end of the esophagus?
There are two autonomic plexus. There is Meissner plexus and...
That is fine, but what do you specifically see in the biopsy? What will be absent? Loss of ganglionic cells. Yeah.
Okay.
Yeah. Fine.
Okay.
Right. So, what are the other reasons? So, this is one. Are you aware of any acquired cause of achalasia?
There is infective cause like Chagas disease, which is more common in South America.
So, what would you like to do now? What next?
Then after this, I will go for contrast study, which is called, which is barium swallow.
You want to do barium swallow or a gastrographin swallow?
It's barium swallow, I think.
What is the difference between barium swallow and gastrographin swallow?
I think it's the main difference to two things. The main thing is that the barium, if we are suspecting in acute situation any perforation, this is not advisable because it's very irritant to the peritoneal cavity, for example, and can cause significant chemical inflammatory process within the peritoneum. While if we are delineating the lining of the upper GI structures and we are not suspecting perforation, then that should be okay. The other thing, gastrographin is got high osmolarity and got other characteristics. In addition, being it's safe to the.
What about the radio opaque character?
Barium is more radio opaque.
Okay.
That gives us more contrast windows to the background tissue.
Okay, fine. I'm just sharing the image. What do you see here?
It is basically there is a dilatation of the. This is a barium. This is a view, X-ray view of the barium swallow test, and it's showing lateral view of the barium, and it shows significant dilatation of the upper, middle, up to the lower esophagus with bird beak appearance at the gastroesophageal junction just below the expected level of the diaphragm, and there is very narrow passage of the contrast to the stomach.
That's fine. What is the difference between a barium swallow and a barium meal?
A barium swallow, it is a test that is being taken, I mean, the view being taken during the swallowing of the contrast, while the meal is after the swallow has finished, and it shows mainly the stomach and how the empty of the stomach, rather than only the swallow of the esophagus and the passage of the contrast from the esophagus to the stomach. And it is the timing, mainly the timing after the uptake of the contrast.
Barium meal, apart from showing the stomach, what else do you check in the barium meal?
These tests, in addition to the anatomy, it is physiological study. So it can, first of all, give us an idea of the anatomy and also the physiology, like how long does it take to empty the stomach,
Fine.
and
That's
if there is
fine.
any delay.
That's fine. This is the barium swallow image. What next? You have seen the barium swallow image. What next?
This is most probably give us a very narrow differential diagnosis here, but to add it more, we can also check the esophageal manometry to give us more information about.
You can check, or you will check.
No, I will.
Mm-hmm. Okay. So what is the idea of doing a manometry in this situation? What does the manometry tell you?
It confirms the type of the dysmotility which is in the esophagus, and this will help us in dictating the other level of the management or the option of the management.
Excellent. Good. Right. So what do you understand by the term vigorous achalasia? What is vigorous achalasia, Kadia?
There are, it is one of the varieties of the esophageal dysmotility where there is a very high tone and non-relaxing of the lower esophageal sphincter. And it also involves, there is also a high tone in the other part of the esophagus as well.
So basically, a vigorous achalasia is basically you have achalasia cardia along with diffuse esophageal spasm. Yeah, that is called as vigorous achalasia. Okay. So what are all the treatment options available for managing achalasia?
If it is a pure achalasia with the lower esophageal sphincter, then there are several aspects of it. One of it is, intervention that helps in improving the situation. One of it is to Botox injection to help in relaxing the lower esophageal sphincter.
What are all the endoscopic options available?
There is POEM, I think, called POEM. In abbreviation, it is peroral endoscopic myotomy, I think. Yeah, that will.
One is POEM. What else? What is the commonest endoscopic intervention? POEM is very rarely done. What is the most commonest endoscopic intervention?
Dilatation.
Exactly, balloon dilatation. So balloon dilatation and POEM are the endoscopic options. What are all the surgical options?
It is myotomy, laparoscopic myotomy with half wrap after this. Usually in combined also with on-table study to make sure that the mucosa hasn't been injured.
What is the main difference between a POEM and a myotomy? What is the main problems?
You mean between endoscopic POEM and
endoscopic POEM and the laparoscopic cardiomyotomy? Yes.
Yes, and laparoscopic.
What is the main difference?
Okay, we incise in the POEM. We incise the mucosa and the muscle layer and preserve. Ideally, we try to preserve. Ideally, to not to injure the serosa, and it is along the area of the lower esophageal sphincter, taking a level of higher than the lower esophagus and going up to.
What is the key difference? I know the technical difference. What is the key difference between POEM and an achalasia? In terms of the post-operative problems.
The laparoscopic myotomy with half anti-wrap operation has better outcome, less recurrence.
More than the recurrence in the immediate post-operative period, why people are more happy following cardiomyotomy, laparoscopic cardiomyotomy rather than POEM? The symptoms of dysphagia,
reflux.
Exactly.
This is the reflux symptoms which will be very bothering to them because there is no anti-wrap sorry, where there is no anti-reflux step in the poem
Exactly.
option.
Good. I'm going to stop you here. Okay. Good.
Thank you.
So yeah, you did very well actually. Means I've been seeing you for quite some time now. Yeah, continue practicing. Yeah, and this is a, to all others, it's a very, very common and a very basic general surgery question you can expect in your exam. Very, very common, very basic question. I didn't twist and turn much actually. And Khaldun did very well. He has been practicing for quite some time now, and nothing much to comment. Yeah.
Thank you.
Any other questions from others? No?
I think we should have asked it for a biopsy if he went for the OGD to rule out any
Exactly. No, absolutely.
Barrett or dysplasia.
Exactly. The reason why I didn't ask that is because my aim of this scenario, I have been asked to check what is the patient's, the candidate's knowledge in achalasia. So I didn't want to waste much time on that. If my aim is to, if it is a, say, a small esophageal stricture leading on to a cancer or something, obviously I would have asked. Yes, you're absolutely right. He should have asked that, this is concerning, and I would repeat an endoscopy to make sure that we are not dealing with a cancer. Definitely, no doubt. Yeah. Good. Right. Who is next? Melvin, you want to take? Yes, Melvin.
Hi.
Right. Okay. So, right. Melvin, so imagine you are doing your general surgery clinic and you have an 60-year-old male patient who is coming to your clinic. This patient had underwent an Hartmann's resection for a perforated diverticular disease 25 years back. 25 years back, he never bothered to reverse it. He was very happy with the stoma. Okay. Recently, for the last 6 months, patient has been having on and off bleeding into his stoma bag. And patient has gone to the GP and the GP has sent the patient to you. In the clinic, it's not in A&E. So how will you approach the situation?
Okay, so I would approach by taking a focused history, paying particular attention to red flag symptoms. So he's already told me he's got peristomal bleeding. I would want to know if he's had any change in bowel habit recently, weight loss, any family history of colorectal cancer would be high on my priority to ask. I would want to know his performance status and previous surgeries apart from the Hartmann's. And his medication history to see if he's on any
patient is a diabetic and a hypertensive patient, okay, but otherwise that's a performance status of 1, okay, lives independently.
Okay.
And in terms of the history, patient had this resection for a diverticular disease. For the last 6 months, patient is finding blood within the bag, and the frequency is increasing more commonly now.
Okay. In the history, I would also want to tease out whether it's per sort of stomal bleeding or it's mixed in with the stool. So that would be important to work out.
Patient doesn't know that.
Okay. I would then proceed to perform an examination, including taking the bag down, examining the stoma, and if he allows me to do a kind of proctoscopy down the stoma just to see the first little couple of centimeters in the clinic as much as I can see. And then perform a general abdominal examination.
Okay, so you examine, general examination, patient is mildly pale, slightly anemic, otherwise rest of the general examination is fine. You're examining the stoma is very beautiful. You see that there is some lot of dilated veins within the mucosa of the stoma.
Okay.
And there are some ulcers there, and you think that that is the source of the bleed.
Okay. I would look for any spider nevi in the rest of the abdomen.
What is spider nevi? Why does it cause?
So basically what I want to know is there any signs of kind of portal hypertension and sort of varicosities? I would also want to do
this is one example of how you can be caught in the exam. Okay, you are right, absolutely right. Yeah, so looking for spider. I can understand that you are trying to tell that patient has any signs of liver cell failure, but if you are answering very well, and if the examiner wants to irritate you, just because you have put this, you are giving a good chance for the examiner to ask, okay, what is spider nevus? Why does it cause? What is the pathophysiology behind that? I can ask you. And what is its significance? Say, imagine a patient, one chronic liver disease patient with no spider nevus, another chronic liver disease patient with spider nevus. What is the difference? I can ask. So, but that's fine. But I'm just telling you, in the exam, when you answer, you need to anticipate what would be the next question following the answer. So if you don't know certain things, you should be very careful and use generalized terms. Instead of a spider nevus, if you had told me I will look for flapping tremors, I will look for jaundice, or look for ascites or engorged vein, that makes more sense. Yeah. Or you instead of telling I will look for spider nevus or Dupuytren's contracture, which no one's seen anything in their life, you should not tell that. Okay, fine. Continue. When you look for signs of liver cell failure, why do you want to look for that?
Because of the mucosal veins that are visible, and that might have an impact on any potential surgical treatment that the patient might require down the line.
No. What are you thinking? What is running in your mind?
He could have colorectal cancer with liver mets, possibly causing some liver failure or something like that.
Why?
Or it could be totally different pathology with the liver.
What different pathology with the liver?
I don't know if he's a chronic excess alcohol drinker, if he's got a history of hepatitis C.
Again, answer in a very simple way. You just want to know whether the patient has cirrhosis with portal hypertension. That's what you're trying to say, yeah?
Yeah.
But the other answer which you told is a disastrous answer. Yeah, patient having a colon cancer with liver mets causing liver failure, causing portal hypertension. By the time patient would have died. Yeah.
Sure.
So again, you should be again, common things are common. Yeah, the common things when you see a peristromal varices is think about portal hypertension. Yeah,
sure.
Fine. So there is no obvious patient is slightly jaundiced when you look at. Otherwise, there is no other signs of chronic liver disease. What next?
So I would need to further investigate luminally to see if there's any other cause of bleeding per stoma. So I would arrange for an urgent colonoscopy via the colostomy. That would be the first blood. So that would be the first sort of test I would do from the clinic. I can also do blood tests, including for blood count, to confirm my suspicion is anemic. I would do liver function tests and albumin to see what his liver function is like, and clotting as well, INR.
Okay, you do all these things. You do a colonoscopy. You see multiple varices here and there within the colonic lumen, yeah, mucosal varices, and you do some blood tests. Patient is mildly thrombocytopenic. Platelet is 140. Patient's hemoglobin is 110. Okay, liver function tests are slightly deranged. The rest of the parameters are normal.
Okay. So his clotting is normal, did you say?
Yes.
Okay, fine. So I've ruled out that there is no malignancy within the GI tract that's causing the bleeding. So most likely it's bleeding secondary to the sort of.
You have not ruled out a cancer from the GIT. You have just ruled out from the colon.
Colonic, sorry, yeah.
Yeah.
Colonic, yeah. Does the patient give a history of any hematemesis?
No.
Is there a raised urea, nothing like that to suggest upper GI bleeds? If the diagnosis was uncertain, I would then proceed to get a CT chest, abdomen, pelvis with IV contrast with a portovenous face.
So you do so what will you look for in the CT scan? I have not put any image here because certain images I cannot put in the open forum. So what will you look for in the CT scan?
So any obvious exophytic lesions within the GI tract, that might be obvious. So large polyps or sort of tumors, evidence of portal hypertension.
Like what will you look for? What evidence of portal hypertension you look for?
Sorry, not sure.
No, what will you look for in a patient with portal hypertension in a CT scan?
Yeah.
So what do you think is the portal hypertension? So portal hypertension is secondary to cirrhosis, isn't it? So what are the same? How will a cirrhotic liver look like in the CT?
So it wouldn't be smooth, so it would be kind of knobbly, I guess. You would see sort of dilated veins where you wouldn't see it normally, sort of around the lower esophagus, perhaps around the sort of rectum.
What about spleen?
Spleen is likely to be enlarged.
So can you have portal hypertension without cirrhosis?
If you had like a chronic sort of portal vein thrombus, you could have, yeah.
Okay, so you do a CT scan and you see that patient has, a shrunken liver, okay, and extensive periportal and perisplenic collaterals, and you see a lot of collaterals in the colon, okay, mesocolon, and you see extensive collaterals within the mucus of the colon also.
Okay.
This is what you see. What next?
I would probably then at that point want to know what's the cause of his cirrhosis. Would be thinking about he would need referred to a hepatologist for initiating sort of medical management with his, which is kind of out with my expertise.
No, that is for your liver. So what are you going to? How are you going to stop this bleeding now?
Is there an obvious point that it's bleeding that I have visualized on the endoscopy?
No, as I told, endoscopy shows multiple ulcers in the colon, and you have these engorged veins, which probably has an evidence of a recent bleed.
So I can't think of an obvious surgical procedure that would stop the patient from bleeding if he's got multiple sort of potential sites where he could be bleeding from within the colon or in the GI tract per se. So what do you think optimizing medical management?
According to you, what is the source of this bleeding?
These ulcerations and the enlarged venous.
Yes. So what is that enlarged? It's a varices, isn't it? It's a colonic varices. Okay.
Yeah.
You have colonic varices which is bleeding. So how are you going to stop this colonic varices which is bleeding?
To try and get the portal hypertension down. Exactly. Then these veins should go down.
Yes.
Which
so
is why I would refer them to.
How do you bring down the portal hypertension now?
I personally wouldn't. I would send them to the hepatologist.
What do you think a hepatologist would do?
So I imagine they would start medical therapy, which would try and bring down the...
What medical therapy? All these prompts will reduce your marks. What medical therapy?
In the acute setting of bleeding, terlipressin, but chronically as a propranolol, perhaps.
Yes, exactly. So you know everything, but you're not answering. This is the problem. I need to pull out all the answers. Yeah. So as I told, more the prompts, lesser. So you know everything, but if you don't answer it, then you are committing suicide for yourself. That's the thing. Yeah. So yes, beta blockers. Yes. So imagine they start on beta blockers, but patient continues to bleed. What do you think would be the next option?
A TIPS procedure, perhaps?
Excellent. Very good. A TIPS procedure. So TIPS is the only procedure which you can do here to stop this bleeding. Okay, good. So having a peristomal bleeding and having a rectal varices bleeding in a background of a patient. So you won't be having a straightforward patient presenting with an esophageal variceal bleeding. Everyone knows. Even a medical student can answer how an esophageal variceal. So instead of that, you will be having a patient who has a rectal variceal bleeding or a peristomal bleeding, and that will lead into portal hypertension. That will lead into so if this patient presents acutely with a massive bleed. Okay, you need to treat like any other patient with esophageal variceal bleed. You start the patient on terlipressin, you give octreotide, you do a colonoscopy. If it is big varices, you can still band these varices. If not, you refer to this one, what is it called, TIPS. If TIPS doesn't work, then you think of any shunt operations and things like that. Okay, and as you rightly mentioned, a portal hypertension is not just because of cirrhosis. You can have a non-cirrhotic portal hypertension, which could be because of extrahepatic portal venous obstruction or non-cirrhotic portal fibrosis. These are the other causes. Okay, good. So you did well, but as I told, I need to bring out your answers from you, or else you're not answering. That's the thing. Again, common things are common in the exam. Whatever comes to your mind is actually the right answer, if at all, if you have enough experience. Yeah.
So am I,
never
just to clarify, so as a general surgeon, I wouldn't ever start somebody on propranolol.
You
So
don't need
am
to
I
start
wrong by saying I would
no.
refer it to the
You will
hepatologist?
refer to the hepatologist, but you should tell that this is a portal hypertension plate. This patient needs a medical management for controlling of portal hypertension, which is propranolol, and if not, a tips might be considered. But I would not do this. I will refer to the hepatologist. So there is a difference here. There, in your answer, you are trying to escape from the situation by pushing the patient and telling, I don't know anything. But here you are exposing that you have this knowledge, but you won't want to do because you have not trained here and you want to deliver that service safely. This is the difference between the answer. Okay. And similarly, you should not straight away tell that I don't know what is the finding in the CT scan. Yeah. So, when you don't tell that what is the signs of portal hypertension in the CT scan, but actually you told everything. When I gave prompts, you told everything. Yeah. So
I just couldn't, yeah.
Exactly. So when you tell you don't know certain things, you need to be very clear in your mind whether you completely don't know or you can't recollect. Okay. For
I couldn't
example,
recollect, so I just wanted to get through the questions.
For
I didn't want to
example,
waste time.
say you have an actinomycosis patient. You have a patient with abdominal actinomycosis. So even 1,000 clues I give you, you cannot know the answer. In that situation, you tell I don't know. But you know something, but you have a thought block and you cannot tell. You can tell something related to it. So the examiner will know that, okay, he knows something, let us help him. Yeah, this is what you need to do. Okay, good. Any other questions from others? No? Okay. Who wants to be the next volunteer? No one? Okay, Alia is coming, wanted to do the second one. Anyone else here? Okay, someone else. Majid Obaid. Hi,
Hello.
Majid. Hi.
Hi.
When is your exams, mate?
September.
What specialty?
I'm giving my exam in trauma.
Oh, you are a trauma. Okay, good. Well, one of the first candidate I'm meeting for a trauma surgery person. Good. So it is quite very difficult to train you, man. Do you have anyone to train you? Yeah, because probably you are probably the first 10 candidates in the whole country to take FRCS in trauma surgery. Do you know anyone who has taken trauma surgery in the past?
Yes.
You have?
Yeah,
Good.
I know.
Excellent.
I
Good.
know.
So because because your specialty came in maybe a year back. Okay, until a year back, we never had an FRCS in trauma surgery. We never had FRCS upper GI had HPB also. So HPB and upper GI got separated. Similarly, as a transplant is changed to just kidney transplant now. So trauma surgery is one which is added. Excellent. Glad to meet you. Good. Right. So imagine, Majid, you are you are the general surgery consultant on call, and you have an 25-year-old female who is coming to you with a right iliac fossa pain. Okay, patient is known stage 4 CKD disease patient and had underwent a kidney transplant in the past. How will you approach the situation?
Okay. First of all, I will attend the patient and take a history. Attend the patient and approach her from A to E with simultaneous resuscitation if needed, analgesia, oxygen, and IV access. And I would take a focus history then of the patient, of the abdominal pain, onset, timing, progression, associating factors. Then take a history about her transplant. When was the transplant? What led to the transplant, and when was the last transplant appointment, checkup appointment. Then after that, I will proceed to examination, general
Fine.
examination.
So this patient says a 25-year-old girl who had some congenital problem some kind of an autoimmune nephropathy and underwent a transplant 3 years back. Okay, and the graft function is perfect. Patient is taking tacrolimus and mycophenolate as an immunosuppression. Okay, and the patient was doing fine. Patient developed right iliac fossa pain 2 days before and has low-grade fever.
Okay. I would like also to know some information about her period. When was the last period? Is there any chance that she could be pregnant?
The patient has irregular periods and had her last menstrual period was 2 weeks back.
Okay. I would like now to do some investigation, starting with the blood tests, including FBC, liver function test, renal function test, coagulation profile, lipase, amylase, and pregnancy test with HCG.
Why do you want to do lipase?
To exclude pancreatitis.
How commonly have you done lipase in your clinical practice?
Sorry?
How commonly have you done lipase? Even when you suspect a patient with pancreatitis, do you often do a lipase?
Lipase is more specific because in this situation, it's not available in always.
Exactly. Yes, it's not available. It is very costly. It is so you cannot tell this. Yeah, it means that you are giving me an impression that you have never seen a pancreatitis patient. Yeah. So as I told, you need to tell what you will do in the UK in your practice. Yeah, not the textbook description. Fine. So you do all these again. Similarly, before I forget, whenever you tell that you want to do some blood test, please never tell I will do some blood test. No, you are not here to do some blood test. You will tell, I will investigate the patient and specifically look for this investigations. Okay, don't use the word some. Okay, fine. So you do the blood test. So in the full blood count, you see the patient's hemoglobin is 120, WBC count is 6. Okay, and you see the kidney functions are slightly deranged.
Okay. Yeah. So I'm concerned now that with multiple differential diagnosis, the top differential is right iliac fossa. I would like to know where the kidney, the graft kidney was implanted. Is it on the right side or the left side?
Thank you for asking at least now. Yeah, it is on the right side.
Okay. So, however, common things are common. Appendicitis on my top of differential diagnosis, ovarian pathology. However, in this situation, also I need to exclude any pathology to the grafted kidney.
Like?
Okay. So I would do my examination.
No. What graft pathology? What graft pathology you are thinking could be affecting?
Okay, in this situation with abdominal pain, I would lymphoseal one of these. Other thing, stenosis of the ureter, hydronephrosis due to that.
What is common? A painful
What's
graft.
common?
Painful transplanted graft. Be it pancreas, be it liver,
rejection.
Exactly. That is the first thing. Rejection. Whatever you told, lymphoseal after 3 years is very rare. Stenosis of ureter after 3 years, suddenly they won't present. Rejection is the most common thing. Okay, good. So these are all the different. What next? What will you do now?
So now I would like to do an ultrasound, and I will do sorry, I would examine the patient with general examination, specific examination, specifically with the area of the pain. Then I would do, after that, I would try to do, order an ultrasound to focus, to
in the
exclude any
clinical
hydronephrosis.
examination, patient has a very severe tender right iliac fossa. Okay. What next? So what will you specifically ask for in the ultrasound scan?
I would ask for the ultrasound scan to exclude appendicitis and to look at into the graft to see any signs of hydronephrosis, for example, because I need to address that, or even a Doppler to for the kidney vasculature.
Good. So you do an ultrasound scan, and the ultrasound scan says that there is some minimal free fluid in the right iliac fossa. Appendix could not be visualized. Normal vasculature of the graft kidney, no hydronephrosis.
Okay. I'm still concerned here because I couldn't exclude appendicitis. I would go for CT scan of the abdomen with IV contrast after I discuss this patient with the renal team to take their advice.
Okay. So the renal team has discussed, and you have taken a CT scan, and the CT report comes as possibility of early appendicitis.
Okay. At this point, I would also take an advice from the renal team regarding management of her medication to medicate very operative complication, and I would discuss with the patient the option regarding conservative management versus going for laparoscopy and laparoscopic appendectomy.
What will you do? You are the only consultant in the DGH who could perform appendicectomy. What you will do?
Ideally, this patient should be operated in a center with a transplant team available to attend to this patient. So I would take an advice, and since it's early appendicitis, or I would try to refer her to transplant center.
So you told you would think of conservative approach also. What is the problem in conservative management in these patients?
So the problem with the conservative management is the lack of the inflammatory response due to the immunocompromise in this patient, and because also there are more they will be affected more in complication if the medical management has failed, because of, for example, perforation would be very detrimental in this patient due to the sepsis
What
complication.
will be your preference? You would like to operate or not operate?
I would like to operate, like I said, because the
But why do you say
complication.
this is an appendicectomy, isn't it? Why do you want a transplant surgeon next to you?
Transplant surgeon, because not only the transplant surgeon, I want the expertise from the transplant team in terms of medication of the perioperative complication and the medication of this patient.
Okay, that you can get over the phone. You don't need a person in place. Yeah, you can get over the phone.
If they're not happy, or I don't have the means to transfer this patient, I could have this from the renal team or the transplant team. However, the anatomy there in that area, because of the implanted kidney, would be very familiar to the transplant surgeon rather
So
than
what do you
general
think would
surgeon.
be the anatomy? Where do they place the kidney?
It would be in the extraperitoneal, in the right iliac fossa, pushing the maybe the cecum from the different anatomy, and I could encounter the adhesions to that area from inflamed or perforated appendix.
Good. I'll stop here. Yeah. Good. So you did very well. You did very well, except for telling this lipase investigation. Yeah. Other than that, you are very sequential, very confident answer. And exactly as you told, you could have asked where is the kidney, on the right side or the left side. That should be the first thing. And as I told, when you tell the differential diagnosis, try to stick to common things as common. And to everyone here, any transplant patient presenting with an intra-abdominal problem, patient needs to be referred to the transplant unit. Okay, say for example, a post-liver transplant patient coming to you with, say, acute abdomen or something, whatever it is, anything to deal with abdomen, patient should be referred to transplanting if options are available. If it is an emergency, life and death situation, you have no option, you can proceed and you can get the inputs from them. But in all other situations, you need to be transferred. Another common scenario which you would be getting is patient having a right-sided inguinal hernia with a right-sided kidney transplant. Again, this is not an inguinal hernia which you can operate. Okay, you need to transfer to the unit. Okay. Similarly, patient with post-pancreas transplant presenting with right iliac fossa pain. Yeah, again, it could be a graft pancreatitis rather than an acute appendicitis. Yeah. So everywhere in this case, from the time you see this patient, wherever possible, try to involve the nephrologist for the medical problems and the surgeons for surgical problems. Okay, but you did very well. Okay, good. Any other questions? No?
Do they normally transfer for, if you're going to do a lap appendix to a transplant unit?
Yes, yes. Because there are multiple, see, you can do it if you do a lap appendicectomy for a kidney transplant. Say if this patient had a kidney transplant on the left side and you want to do a laparoscopic appendicectomy, still you can do. But if I am a consultant, I would not do it if I'm not a transplant surgeon, mainly because few things. One is, yes, this, as long as you are doing it laparoscopically, if it is fine. If you want to convert to an open operation, and if you do a lower midline laparotomy or something, you would encounter the bladder where the ureteric anastomosis is there. Anything can go wrong. Okay, for example, you do something and patient develops a rectus sheath hematoma or a pre-peritoneal hematoma or something. So you should have these people around to help you. So whenever possible, transfer this patient to a transplant unit where a transplant surgeon is available. Yeah.
So, Mani, can I add one thing? Oba's answer, I need to add during my assessment of this particular 25 years old female patient to involve my gynecological team to exclude any gynecological symptoms.
Yeah, but you don't need to do it from the beginning itself. Of course, you will do an ultrasound scan. If the ultrasound comes back as pre-fluid and say an ovarian cyst or something, then of course you will involve them, not from the beginning.
Okay, thank you.
Mr. Mani?
Yes, Mohammed.
You said if it is a life-threatening a patient with transplant, so you need to operate on like
yes.
Life-threatening, like bowel perforation.
Yes, bowel perforation. See, when I say life-threatening, bowel perforation, and if the patient is hemodynamically stable, still you can transfer the patient. Yeah. So the entire NHS is arranged in a way that every system and the services are available at 50 to 70 miles from you. You can still blue light this patient to a transplant unit. Okay. When I say a life and death situation, say for example, patient who had a liver transplant coming to you with a trauma with bleeding, and you cannot transfer and has a splenic grade 4 splenic laceration. Okay. That you need to operate, of course. Not again, peritonitis, if the patient is hemodynamically very unstable, then of course you have to operate. But if they're stable, you can still blue light the patient to a transplant unit.
Okay, thank you.
Yeah. Any other questions from others, guys? No? Right. Let me take one more scenario. Nazia, you want to go?
Yes.
Yes. So where do you work?
I work in Cork.
Okay. When
in Brest.
You are giving September exams, yeah?
Yeah.
Good. Right. Okay, Nazia, so you imagine you have become a consultant now. Okay, you become a consultant and you are doing your first elective list. In the elective operation, you have like 3 open inguinal hernia repairs. Okay, and you have a very senior registrar with you. And you are asking your registrar to start the operation. The first case is a right-sided inguinal hernia repair. And you are getting a call from the theater as emergency. and you're going there, and you come to know that patient had a left-sided inguinal hernia repair instead of a right-sided inguinal hernia repair. Patient is still under anesthesia. How will you approach the situation? Are you there?
The patient was supposed to have the
Yeah, patient was supposed to have a right-sided inguinal hernia, okay? But the registrar, because there was 3 cases, he got confused. He marked the left side, and your registrar has done the repair also, and he is closing the skin. At that point, someone has picked up that patient had a right-sided inguinal hernia. Then the registrar realizes that he has done a mistake. So he is calling you. You are there. How will you approach the situation?
So I would come and discuss with the registrar where actually the fault occurred. Actually, the marking has been done beforehand. That's why the problem occurred. But
No, marking has
primarily the
been
patient
done.
was
Marking has been done, but he has marked on the wrong side.
okay. So there had been some fault in marking or identifying the side of the surgery being operated, but the patient was meant to be operated on the right side. So my preference would be to operate the right side while the patient has been anesthetized, and then we can find out the point where actually the problem occurred.
So you will do a bilateral. So patient coming with unilateral hernia repair, and you did a wrong side, and you want to do the other side also now.
Because this was a planned procedure that we were supposed to do. So yeah, so I would like to go with the planned procedure.
So you will do the right sided. Okay, imagine you did the right sided operation also. Okay, and what will you do now post-op?
So it's my duty of condor to explain to the patient that what went wrong with the during the surgical procedure. So I would address at 2 points, telling the patient where the things went wrong, and telling to the registrar where actually he didn't do the right thing. So I will tell the patient that we were supposed to operate the right hand side, but because of the marking error, he's been operated on the left hand side. So then I will tell that what are the consequences of operating bilaterally in terms of having as if he was supposed to have a pain on the right side, but now he might have pain bilaterally. He would have scars bilaterally. In terms of management, as he had the bilateral hernia pre-handedly, so he's been dealt.
So
patient in the same
becomes
setting.
super furious. Patient is furious and shouting at you, telling that I consented for a right-sided unilateral operation. I never consented for bilateral hernia repair, and you have done a wrong side operation. And you should have woken me up, or I wouldn't have had the operation on the right-hand side. This is what patient is shouting. How are you going to deal with this?
So I would explain that because the required surgery was on the right side, you were more symptomatic on the right side. So if I would have not operated that side, so that would be causing you problem
Patient
in
is
the
telling that
post-op period.
how you can decide that. It is my body. I never consented you, never told you to operate on both sides. I gave consent only to operate on one side, which you did it wrongly. And who gave you permission to operate on the other side?
Actually, we had the consent for the right hand side.
Yeah.
So we were supposed to operate the right hand side. So mistake was made on the left hand side. So it's our duty of condor to apologize for that. But we are at the same time we are operating the required side that has to be operated.
Fine. So you tell all these things. Patient somehow at the end agrees to whatever you say. What else you will do now? What next?
So I would check with my team working in the theater and my registrar as well. So I think right from consenting the patient till the patient has been signed in and the incision was given. So WHO checklist had not been followed. And then I would identify the problem where actually was it the
so when you are dealing with all these things, because this is the first case in your list, you have 2 other patients in your list. Okay, will you cancel the other 2 patients, or you will still do, or what are you going to do?
We will deal with the rest of the patients according to the list, and but we will be more meticulous in knowing the site and the procedure to be done. A WHO checklist protocol should have been followed, and the site and the identity of the patient should have been correctly identified
No,
by
those
me and
things
by
are
my.
fine. So this patient had a wrong-sided marking, yeah, and everything else was absolutely fine. They had done the WHO checklist and stuff. So you came back to theater. You are going to explore this. The only mistake was a wrong-sided marking. What you would do after this? What else you will do pertinent to this case?
So pertinent to this case, I would pay more emphasis on asking the patient
No, that is
before marking.
future. That is for future and with other patients. With this particular case scenario, you went and told the patient, you came back, you asked your registrar, what else you would like to do? Would you file anything? Would you put anything in the computer?
So I would register this as a missive no event.
Near miss event, yeah.
Near miss event, yeah.
You will put a date X. You will put a date X, and you will do a root cause analysis and stuff. Okay. So you do this. Okay. You do all these things, and say because this is your first theater list as a consultant, and this is your first case in your career as a consultant. Okay. Now the whole general surgical team is thinking that they would have lost confidence on you. Okay. How are you going to win the confidence of them? How are you going to prove then that, okay, this is not going to happen anymore? How will you recover from this?
So I will try to start with my next case and making sure that the patient has been told before being anesthetized which side the patient has to be operated. The site is properly marked, counter checked by the notes as well, and then moving forward with that list onward. And then as the cases will go on respective lists, so the confidence will be gained in theater in that way.
What else?
So sticking to the WHO checklist and improving ourselves in terms of knowing the exact site is been.
Okay, let me stop here. Okay, so in the exam you will definitely have one or maybe two clinical governance scenarios. Okay, you will have a wrong site operation, or you will end up having some other problems and performing duty of candor and stuff. And these are all the scenarios which gives the opportunity to the examiner to check whether you have enough knowledge on the NHS clinical governance principles. Okay, the first important thing is whenever a mistake has happened, you need to go there, stop the procedure. Okay, when a mistake has happened, if I am the consultant, I would not operate on the other side. Okay, I would have stopped the operation there. I would have woken up the patient. I will tell this has happened, and I will get the prior further consent before I go ahead and do on the right hand side. Okay, patient has consented, yes, for the right-sided inguinal hernia, but patient has never consented for a bilateral inguinal hernia. You are not allowed to do anything, assuming that the patient would accept that plan. Okay, there are two ways to approach this. One is either you can call the next of kin, okay, until this has happened. However, still, if the patient has the full capacity, the next of kin cannot make a decision on behalf of this is not a life and death situation to take a decision on behalf of the patient's best interest. This is not a life and death situation. But again, a next of kin cannot make a decision for the patient when the patient is anesthetized. So when a massive mistake has happened, which is picked up, you need to stop the procedure at that point. Make sure, so the important keywords here is, I will go there, this mistake has happened, I will make sure that the patient safety is prioritized. Whatever side has been operated, I will make sure that it has been done perfectly. I will stop the procedure. I will wake up the patient. Post procedure, again, I will make sure that the patient is very, very safe. I will go speak to the patient. I will perform the duty of candor. I will apologize to the patient. You never use the word apologize. You answered in a way that this has happened, I will tell this patient. No, I will apologize to the patient, explaining that these mistakes have happened, and I will be transparent, and I would take the accountability of whatever has happened. These are all the words which is very, very key, very, very important. I will take the accountability of the thing. I will apologize that these things have happened, and I will reassure the patient that although we have done on the opposite side, we have made sure that this is not going to cause any harm, and we will further investigate this to see what has gone wrong, and we will get back to you with the investigations which has done in the background. And you have to offer the patient that if you are seriously concerned about this patient, you are open to file an investigation, or you can ask if you need any further inputs on whatever wrong has happened. Okay, this is one thing with the patient. And then you need to tell that because this has happened, because you have consented for one procedure, one side only, we have woken you up, and we will prioritize you in the next list, if at all, if you wish to go ahead with the repair on your problematic side. Then you come back to the theater. I will perform a debrief session. I will keep the anesthetist, registrar, everyone, and I will discuss step by step what has happened to do the root cause analysis of the problem. These are the words which you need to use. And you tell that these are all the problems, and then you will put a DATEX complaint, and you will discuss in detail, volunteering by yourself to make sure what has happened. In the future, I will make sure this is prevented by myself available, at least for my initial few cases, because I have just become a consultant, to make sure that these mistakes never happen. Okay, and how will you win the confidence on this one? You need to tell that you will be open to everyone. You volunteer yourself and take this patient voluntarily by yourself to the morbidity meeting. You will present yourself, and you will tell that this mistake has happened, and you will list out what are all the things you will do to prevent further things happening. So you will tell that this is a mistake which has happened, 100% it is preventable, but I'm making sure that this will not happen in the future because I am going to do this. Okay. Sometimes you can even tell that I've also applied for a course to making the patient safety, and the patient safety course or something you can do. Okay. So this is how you answer the situation. All right.
Yeah, thank you.
Any questions, guys, from others? No?
And would we continue with the rest of the list?
So again, it's up to you. What I would have told is, because it's a serious problem and I need to deal with the patient, I would look for other consultant who could come and help for the patient. Okay, come and finish my list. Okay, if it is just 2 hernia cases, you can still postpone until the afternoon, and you can do these 2 cases in the evening. If you have 5 cases, okay, obviously dealing with this and dealing with other patients is not advisable, because you are obviously extremely stressed and you are going to perform an unsafe procedure for the other patient. So if I were you, as I told, there's no right and wrong answer. As long as you substantiate things, it's fine. Okay, I were you, I will tell that I will not continue with my list. Either I cancel both the patients, or I will look for some other consultant who can take over. This is what I would say.
Okay.
All right.
Sorry.
Yes.
How about speaking to the registrar?
Yes, you need to speak to the registrar. So in the debrief, you will be speaking to the registrar, and it is advisable. So again, because this is a mistake by the registrar, yeah, although you are accountable. So exactly like how you do certain steps to win the confidence of the others, the registrar also has to do certain things. Like, for example, you should advise him to go and attend a course on patient safety. Or if there is something related to WHO checklist and stuff, this one. And you need to be transparent and telling all these things. And probably this registrar, you will tell that from the next case onwards, I will make sure that he tells one of the consultant before he proceeds with the operation in terms of certain things. Whatever you do in a practical way and day in, day out, you need to tell. Yeah. There is no specific right or wrong answer in these situations, but what is very, very essential is you need to stick to the principles of clinical governance. Yeah, being accountable, transparent, performing duty of candor, or this root cause analysis, presenting in morbidity meeting, registering a DATEX. These are all the important points here. All right. Good.
Yeah.
Yes, Nazia. Anything, Nazia?
So, regarding duty of conduct, so just like saying that this mistake has happened, we apologize for that, and whatever is required legally or officially, if you want some documentation, that could have been provided.
So you don't need to tell a patient that if you want to file a case against me, you can go and you don't need to tell that. You need to apologize, and you
Yeah.
tell that you need to tell that we will investigate this and we will give you a report of whatever investigations has been happened. And
Okay,
if you need further information, you can file and you can send an email or you can approach our PALS team, PALS team, who would be able to help you in getting these records and stuff. All right?
Yeah, yeah.
Good. So what I'm going to do
Thank
now is I'm going to stop the scenarios. I have 5 more slides to tell about the upcoming course for whoever here who have registered. I'll just finish in 5 minutes and then I will open the thing for discussion. Yeah, let me share my screen. Can you see my screen? Yes. Right. So this is what I wanted to discuss at least one scenario in each, but we didn't have much time. So I just want to give a brief overview about the course. So we are starting our 7th edition of our FRCS course, which is starting next Sunday with an orientation. And this is the schedule of our course. So what we generally do is, every Saturday and Sunday, we will be splitting the whole group into group of 6 or 7. We'll have 3 or 4 groups, and each group will be, the group starts at 6 o'clock in the evening, goes up to 9 o'clock, and each room there will be one faculty, and the teaching and discussion will be based on vivas like this. So we will put a question, you answer it, and we will discuss what is right and what is wrong. So similar. So this is exactly what we'll be doing in the course. When you move on to the specialty, what happens is all the specialty candidates will have a separate session with the specialty faculty. For example, on 29-30 on the breast surgery, the evening sessions will be for non-breast trainees, where you will be asked questions at the level of ST5 and ST6, and we will be discussing a level of knowledge up to ST5 and ST6. But the breast surgery specialty trainees, they'll be sitting in the morning between 10 o'clock to 1 o'clock. The breast specialty trainees alone and the breast surgeon will be sitting, and they will be doing 3-hour session on a Saturday in the morning and a 3-hour session on a Sunday. So this is what on the specialty days it will happen. And then we have last 5 days of mock waiver, which will be exactly like your actual exam, which will be starting from morning 8 o'clock to night 9 o'clock. And you will be given specific schedule on which you come and participate, you finish and you go and you'll get the mark sheet. As I told, this is a 3-month program, and it is kind of a mentorship program. Gradually, we introduce the topics. So you will be constantly in a preparatory mode, and constantly you will be discussing and answering. So the preparation will be quite good. There are a few candidates here who have been in our course in the past. If at all, if you need to get some insight from them, how would you like to approach this course? And as I told, the entire course is accredited by the Royal College of Surgeons of Edinburgh, and every hour you participate will be awarded a CPD point. And all these sessions will be recorded, and it will be available in our PrepMedico app or the web portal, which you can access for the whole period of 3 months. Then we have the rapid review lectures. Again, this is not a traditional lecture where we put slides and we read through these slides. It is all, again, an interactive lecture where we will be discussing like a case scenario. We'll be discussing what is right and what is wrong. And all these lectures are specifically exam focused. Yeah, it is not something like we'll teach so many things. So we will be going by scenario, what common scenarios they ask, what specific questions they ask in a particular scenario. These are the way the lectures are devised, and most of these lectures or 3 to 4 hours lecture. Actually, to be honest, it won't be less than 3 hours. And again, all these lectures will be recorded and it will be available for you to access. And as I told, it's a mentorship program. The success of our program so far is because of the gradual, unsystematic introduction of topics. And basically, as I told, the training will be based on what specialty you fall in. Okay, instead of bombarding everyone with all the topics, an upper GI person will be given more of an upper GI knowledge and whatever knowledge he needs in the other specialty. Similarly, all other specialty candidates will be handled based on what that particular candidate needs for the exam. We don't have the long, tiring lectures. Even all the lectures will be exactly like this, where it will be a two-way interaction between the faculty and the candidates. And what not to expect is, obviously, we won't be spoon feeding the knowledge. Many candidates, when they come for a 3-month course, they all assume that we'll be teaching everything, but we won't be teaching. Our main focus is to technically correct your Viva techniques. Okay, that is one. And of course, impart you the essential knowledge needed for this exam, and practice. That's the most important thing. So you will be practicing every weekend. You come here and it becomes a routine for a period of 3 months, in a way that when you go for the exam, the candidate should feel that it is like any other day of a course rather than coming as a separate exam. So if you speak to our candidates in the past, they all will tell this, definitely the anxiety factor on the day of the exam is definitely a lot less because of this constant and continuous practice. Okay. And this is how we do. So every month, so every day you attend, every weekend, your performance will be graded by the faculty. And at the end of 1 month, you will get a report of how you performed in everything. So the faculty, they will grade you whether you are good, bad, or strong, and we will give you a feedback of your personal, strengths and techniques. So we will tell whether your Viva technique was good, how was your professionalism and stuff. This will be your first month report. Similarly, at the end of 2nd month, you will have another report stating how have you improved from what you have been 1 month before. This will be your second report. And of course, the mock exam results will be exactly like scored, like how it is done in the actual exam. This is what we do, and we make sure that the groups are very, very small so that you get more one-to-one attention. And yeah, these are the things. And as I told, it is accredited by the Royal College. And also, most importantly, apart from the weekend sessions and the lectures, we have a Telegram group where all the discussions will happen. The reason why we have kept in the Telegram group is mainly because, we discuss a lot of contents and stuff which might be copyright protected. We need to make sure that the contents are protected and it is used just for discussion. So in the Telegram group, I know most of the people here who have registered already, you would see that the Telegram group is split into multiple subjects: general surgery, colorectal, upper GI, transplant, everything. So almost every day you will be having discussions in every group. And anytime you have any doubt, you can post question there 24/7, and the faculty of concerned specialty will address your query, whatever it is. Whether it is a knowledge-based question or a recent evidence or any, you have everything, we should be able to sort out through the Telegram group. Again, as I told about the LMS, we had invested a lot to make sure that the experience for the candidates is very, very good. So everything, as I told, your weekend sessions, the lectures, and we have compiled all the essential materials you need based on each specialty as an e-library. And fourth thing is, apart from all these things, we also provide everyday MCQs, single best answers. Although the single best answers are specifically designed for the Section 1 candidates, I personally insist the candidates to do this everyday questions. Every day we post 25 questions on that particular topic. If this week is for general surgery, you will have 25 questions in general surgery on day 1. Next day 2, you have 25 questions. This is the best way for you to learn the knowledge essential for the exam. Okay, even if you have passed your Section 1 exam, I insist everyone to do this single best answer just to learn for the sake of the exam. Okay. And this is, a rough idea of how we do this mock exam. This is the schedule which we did for the previous course, which just got over. So the mock exam happens on 4 days. It starts on 3 rooms, happens simultaneously. It starts in the morning and finishes at the night. And we will be providing a schedule like this. Exactly, this is the exact schedule with which you will be receiving for the actual exam. You will have a schedule and they will put your name in different time slots. You just need to be present at that particular time slot to do your exams. And this is our total cumulative hours of teaching which we did in our 6th course. Okay, so if you see 119 hours of mock waiver, these are all we had 50 hours of rapid review lectures, and this is the amount of hours which is which we had delivered different mocks and stuff. So anyone, so most of you in this group, I think you have joined our course, and if anyone are keen to join the course, we still have maybe 2 or 3 participant spots, but we still have plenty of observer spots if someone wants to join us and observe. Okay. Any other questions, guys? I think I had finished whatever I want to convey to you guys. If you have any questions, you can ask me. Yes, Kaldo.
Yeah, just what are the significant, I mean, what's the difference exactly between observer and participant in terms of access?
Okay, so the observer, obviously, they won't be answering any vivas. They will be just observing things, yeah? And obviously, second thing is they won't be in the Telegram group. So because if you see, almost 30% of the course activity happens in the Telegram group where all the discussion happens. And as an observer, you won't be there in the Telegram group. You won't be included in the mock exam, and you won't be participating in the Viva.
Okay, thank you. Thank you.
Mr. Mani?
Yes, Mohammed.
Yeah, for those candidates for section 1, you said there will be 25 questions
every day.
Every day. What I should do more? What I should do? Yeah.
Exactly. So, so section 1 exam, I would say, is the most difficult exam than the section 2 exam, because section 1, you cannot predict any questions, what comes and where. There are plenty of question banks available in the thing. Okay, so we have a question bank. There is higher FRCS question bank. There's something called EFRCS, and there are plenty now. There are 7 or 8 question banks available now. And there are few books. There's an Oxford book. There is something called as a green book. I don't know the name of it. So what I would advise is, one is definitely you need to do question practice. You need to stick to 2 or 3 question banks. Okay. There are 2 textbooks which I can share you later. There are 2 textbooks of which definitely you should do 1 textbook, which is that Oxford book, and you need to stick to 2 or 3 question banks. The reason why you want to do these question banks is because, again, this exam is an intense exam where you cannot be spending a lot of time answering questions. Okay, so you need to do 10 questions in 10 minutes and then study about this, then another 10 questions in 10 minutes. So it is not just learning the theory, but also practicing the questions with the background clock ticking. Okay, that's the important thing. So I can share you some good question banks which I can share you, but the key thing here is it's your foundation knowledge. As I told, how much ever you prepare in this question bank, you may not have even a single question from any of these question bank coming in your exam. So what helps you on the day of exam is, 1 is your foundation knowledge, and the 2 is how fast you are able to work out all the questions. So working out and using these question banks will help you in the time management, and joining this course and answering and doing all these lectures will help you improve your knowledge. So that's how it is.
Yeah, please share.
I will share. I'll share. Definitely. Yeah. Good. Any other questions, guys? Anyone else? No? Okay. Good. So if you have no further questions, probably I will wind off now. And I think the next session is on Wednesday or Thursday, if I'm not wrong. Okay, we will put up the meeting link in the group, and we will catch up again. for another evening with some scenarios similar to this, and you can have some hands-on experience of answering this. And feel free to put up any questions in the preparatory groups if you're there, and whoever here, most of you here are registered for the course. I think if you have any problems and any questions, please put up questions in the course group and we will be happy to answer. And the library access for the course will be provided on the day one of the course, will be next Sunday. Next Sunday, we will give you access to all the library materials. Yeah, because that has been a constant question which you have been receiving. Yes, Abdullah. Can you unmute yourself, Abdullah? You have any questions? No? Okay, fine. All right, then. Thank you very much, guys. See you next week. Bye.
Thank you.
Bye. Bye.
Thank you.
Bye. Thank you.
Thank you very much. Thank you.
Thank you.